I think about a lot of issues, antimicrobial stewardship, because that's probably one of the biggest tools we have with us in preventing antimicrobial resistance. So I was asked to give a talk on stewardship, and we'll just talk about that briefly, maybe for another 20 minutes or so, and then happy to have a discussion after that and answer any questions that you may have. Okay. All right, so just to start off, my name is Lois, as I was introduced earlier. I'm an ID specialist and I teach at the University of Nairobi and offer clinical service at KNH. So I have a few declarations that are indicated there. So I think we'll start by just an understanding of what is antimicrobial resistance. So one, resistance is a trait of a bacteria. Yeah, many times I hear people say the antibiotic is resistant. Usually it's not the antibiotic that's resistant. It's the bug that is resistant. And what this means is that the bacteria can no longer be treated by a certain antibiotic class. And we have single class resistance, for example, resistance to penicillin only. You can have multi-drug resistance, which is like 3 different antibiotic classes. So you have resistance to penicillin, to cephalosporins, to quinolones, or to many other antibiotic classes. And the more, of course, the more resistance the bug has, the more difficult it is to treat. So what are some of the mechanisms of resistance? So one, you can have enzymes that degrade an antibiotic. So for example, if we talk about penicillinases, extended spectrum beta lactamases, these also degrade penicillins and extended spectrum beta lactams. Some may prevent penetration of the drug, either by altering the binding proteins, so that the drug is no longer able to penetrate the cell wall. Some can alter the drug target site, so different bacterial enzymes may be altered such that the antibiotics are no longer effective. And increasingly, we may have efflux pumps that once the drug penetrates into the cell, it's quickly pumped out of the cell. And this is something that's used by organisms such as Pseudomonas, for example. They're able to pump out a lot of different drugs, so you end up with resistance. And the resistance can either emerge because you have random mutations in bacterial genes. Bacteria like each other, so they may share their genes with one another. You may have plasmids that can jump from bacteria to bacteria, and that often leads to very widespread resistance. So that you have a resistant E. coli in one patient in a new unit, but because of sharing of these resistant genes, the Klebsiella is also then resistant, and Aspergillus is then resistant. Okay? And the reason why we always have to think about this is that unlike let's say antihypertensives, if you take a blood pressure medicine, it's only your blood pressure that drops. Even if you overdose on blood pressure medicine, it's you who gets hypotensive, no one else suffers. Unfortunately, for antibiotics, if I take a lot of antibiotics and I select for resistance genes, very distracting. Okay, so if I select for a lot of resistance genes, then I can also share those with other people. So it's not an individual problem, it's actually a community problem, and we really have to think about resistance at that level. So what do we know about the level of resistance that we have? This is a paper that I like to refer to a lot, published sometime last year. And we're looking, it was really a review of all the data that has been published around resistance. And they're looking at how much mortality is actually associated with or attributable to resistance. And basically what you can see here, let's see if I have a cursor. Oh, you can see my cursor, yeah. Basically what it shows here in the very dark bars is attributable resistance. Like this patient died because of this resistance bar. And in the lighter bars is associated resistance. The patient died while they had a resistance bar. It may have contributed to it, but we know that at this patient's death or at the death of this population, there was resistance in there. What is concerning about this is one, there's very high associated deaths. If you think of 5 million deaths in a year, that's more than we saw with COVID, for example, globally. So this is not something that we can ignore. But even more concerning is that majority of these deaths are in resource-limited settings. So if you can look at the left side of this bar chart here, Western Sub-Saharan Africa, Eastern Sub-Saharan Africa are carrying the second largest burden of associated or attributable deaths to AMR. The other thing is that if we look at something like Klebsiella pneumonia, and I pick up Klebsiella pneumonia because for those who are in hospitals, this is something that we're really struggling with, causing outbreaks even within newborn units and within critical care units, and Klebsiella resistance has become quite a big deal. If you look globally at how much carbapenem-resistant Klebsiella pneumonia will be contributing to bloodstream infections, and this is bloodstream infections, very high in the areas around the Middle East, in Southern Asia, up to 65% in India, for example, which means if someone has a carbapenem-resistant Klebsiella, what options do we have to treat them? It means for a bloodstream infection, I think, can I get colistin, which is very expensive, it's very toxic. Patients often will end up with renal insufficiency, or I think in one of the newer antibiotic and enzyme inhibitor combinations, things like ceftazidime avibactam or meropenem avibactam, some of which are not available here, and we don't even have a clear pipeline for when they will be available in our context. So when you have such high resistance, it means the patients in ICU are dying, your neonates are dying when they have these infections. We have little data from Africa. We see from South Africa 18%, and I'll show you some from some of our contexts that suggest that CR infections may already be close to about 10%, and we can't afford that because we don't have options to treat these patients. This is data from our program, AMS, the Kenyatta National Hospital, and looking at E. coli and Klebsiella in blood culture. In the darker bars is E. coli, and in the lighter bars is Klebsiella pneumonia. And here we're looking at susceptibility of these two bacteria to various classes of antibiotics, and I just highlighted a few here. So what we know is that, for example, for amikacin, we have excellent susceptibility, 100%. I keep losing my cursor. Okay, yeah, there it is. 100% for E. coli, about 90% for Klebsiella. What is concerning for the next bar is actually carbapenem, so meropenem. And you can already see that 89% susceptibility of E. coli to meropenem. That means that about 10% of our BSI infections may be because of a carbapenem-resistant bug. A lot of this data comes from a critical care setting, which often may overestimate the level of resistance that we see. The other thing is that if we look at the cephalosporins, which are the commonest antibiotics that we use generally, for example, between ceftazidime and cefotaxime, in between there is susceptibility to ceftriaxone, which is the commonest used antibiotic in many patient settings. And we can see that the susceptibility to ceftriaxone is quite low. For Klebsiella pneumonia, it is about 18%. So we have to start asking ourselves the question of, is this an appropriate empiric antibiotic choice at all in many of our contexts? Looking at national data. So this is data that comes from about 17 surveillance sites in the country and put together by the National Public Health Lab. Again, for Klebsiella susceptibility, this is Klebsiella from multiple sites, not necessarily a bloodstream infection. But again, we can see that for meropenem, already we have about 10% carbapenem resistance. And this is something that's truly scary because, as I said earlier, the options for treating carbapenem resistance in our context is very limited. So what is our solution to this? It shouldn't be, can we get the next big antibiotic? Because we won't afford it, it will be toxic. We have to think about how do we go back? How do we go back and make sure that we reduce the level of resistance so that we can appropriately treat our patients. When we look at bugs such as Pseudomonas or Acinetobacter, again, you can see that the level of resistance in the red bars is again extremely high, even to amikacin, greater than 25%, to meropenem is about close to 75%. So again, we really have to protect patients from acquiring hospital infections that could be caused by bugs such as Acinetobacter or Pseudomonas, because these are particularly difficult to treat. If we think about our patient outcomes, what determines whether a patient walks in and out? What determines whether, if one of us, God forbid, is admitted to the ICU, we can actually be adequately treated and go home. And here will be an interplay of many factors that sort of trying to depict to this image on the right. So there are patient factors, things like age, number of comorbidities, the severity of illness that a patient has, the bacterial factors, so virulence of the bacteria that you're talking about, and resistance of the bacteria, because resistance will determine the adequacy of treatment, adequacy of empiric choices of antibiotic. Then, of course, there are treatment factors. And treatment factors is not just whether you use meropenem or not. It's basic things like you identify the right site of infection. Did you use an antibiotic that's appropriate for that site of infection? So things like penetration to the site, taking into account pharmacokinetic and pharmacodynamic issues. Did you dose the antibiotic appropriately? Was it given for an appropriate duration? And those are the things that come into play when we think about patient outcomes. And we have to think about all those whenever we're managing patients. How does antimicrobial resistance per se influence health? So one clinical implication is that if you have resistance, the chances that you choose an appropriate antibiotic from the outset are limited because you will not know the susceptibility pattern of that bug. We end up using, as I mentioned earlier, more toxic and less efficacious drugs. So the interesting thing is that if I have a Staph aureus that is susceptible to oxacillin, using oxacillin will give me the best outcomes. If it becomes resistant to methicillin, so I have an MRSA and I have to treat with vancomycin, my outcomes are poorer than if I had a susceptible bug. If I have an E. coli that I can treat with amoxicillin, I will have better outcomes than if I have to use colistin for that E. coli, because whenever there's resistance, the rate of mortality is about 3 times higher than when we have a susceptible bug. In terms of a more societal issue is in hospitals where you have a lot of resistance, and I work in many hospitals where I wouldn't want to be admitted into the ICU because I'm so scared I'll get this pneumonia and the other thing. It's not just that patient that is an issue, as I said earlier, it's an issue for every single patient who goes through that unit. Right? So one of the biggest reasons for antibiotic resistance is antibiotic use. And as it says here, antibiotic resistance follows use like night follows day. This was a systematic review that looked at the odds of having a resistant bug after using an antibiotic. So at the top, we see the odds of using the odds of having resistance 1 month after taking an antibiotic. And there are different antibiotics listed there, amoxicillin, trimethoprim. The odds of having a resistant bug 1 month after taking an antibiotic is about 4 times. So 400% higher risk that a bug will be resistant within 1 month of antibiotic use. Within 3 months of antibiotic use, which is follows there, which follows that, the odds are about greater than 2, about 2.5. Higher odds of having resistance within 3 months of antibiotic use. Within 6 months, so I used amoxicillin 6 months ago, the odds that I may have a resistance bug is still about somewhere between 2 to 3. And even after 12 months, so if you use an antibiotic and then ask even in this room for those who are here, how many have used an antibiotic in the last 1 year? Let's be honest, how many people have taken an antibiotic in the last 1 year? Okay, well, you're my only friend. So in the last 1 year, the odds that if you got an infection now, you'd have a resistant bug is still about 1.5 to 2, which is high. Yeah? So do not use antibiotics. I can't remember the last time I actually took an antibiotic because most of those things are viral anyway. I'll just take for a couple of days and get better. So it's not just the patients you prescribe for, it's even for us as healthcare workers. So why is this a concern? Because globally, we're seeing an increasing trend of antibiotic consumption. So looking at this data, for example, and this is percentage change in antibiotic consumption per capita in a period of 10 years. Look at South Africa, greater than 80% increase in antibiotic consumption. And in many places, you have significant increase. Some people are doing well, they actually have a decline in antibiotic consumption, and that's what we should all be aiming for, knowing full well that more than 90% of the antibiotics that we use are unnecessary. Okay. Looking at our own data nationally, so we've done some point prevalence surveys in different facilities in the country to look at the prevalence of antibiotic use based on the point prevalence survey. And these are hospitals in different counties. So for example, Thika, level 5 hospital in Kiambu County, and then you have all the rest. And what you can see here is the prevalence of antibiotic use nationally is close to 50%, right? In some hospitals, it's just above 50%, but generally it's about 50%. And this means that if you walk into a hospital and you're admitted today, chances are 1 in 2, you'll be on an antibiotic for whatever reason. So antibiotic use in hospitals is really high. The next question we had here was, what antibiotic are we using? And again, as I mentioned earlier, the commonest antibiotic, whether it's in a private facility, public facility, is ceftriaxone. Yeah, and I'm sure that comes as no surprise to all of you. So we're using a lot of ceftriaxone. Others are things like metronidazole and the rest, and in some of the higher level facilities, meropenem is already rearing its ugly head. And that's something that we must think about. How do we reduce the use of broad spectrum antibiotics? And beyond this, then goes back to what we were talking about earlier about the prevalence of AMR. When we use broad spectrum antibiotics, like ceftriaxone, for example, what we do is that we select for a lot of extended spectrum beta lactamases. So that then pushes you towards wanting to use a carbapenem. And the more carbapenem you use, the more you select for carbapenem-resistant Enterobacteriaceae, which then pushes you to either having nothing or using fairly toxic drugs. And if you look at this, this is sort of a side-by-side comparison of the commonest antibiotics we use versus susceptibility of E. coli, resistance of E. coli in the country. So if you're using ceftriaxone as the most common antibiotic, here, our resistance to ceftriaxone is at about 75% generally. So we need to rethink what antibiotics we use. And this we'll have to think about over and over. We cannot be using our commonest empiric drug is the one that we have the highest level of resistance to. And what can we do then? So there are multiple strategies to reduce the burden of antimicrobial resistance. And here we're looking at the number of deaths prevented per 100,000 people because of resistance. So improved hand hygiene is probably the one thing we can do. Infection prevention and control has to be core to all our antimicrobial stewardship initiatives. Stewardship programs, environmental hygiene, and I'll give you an example of some of the work we're doing on environmental hygiene. So if we look at the cost effectiveness of these measures, improved hand hygiene is probably the most cost effective. Just by improving infection prevention and control is the most cost effective way of reducing resistance. Then, of course, setting up stewardship programs so that we think about what are we using, why are we using, when are we using, how do we reduce use of antibiotics as we discussed. Then there is the issue of environmental hygiene. We're currently doing some work in a number of hospitals in the city where we're doing surveillance for Candida auris. Candida auris is one of the most resistant Candida with very high associated deaths. And we found quite a high prevalence of immunization with Candida auris over the last about 2 or 3 months. Every day we're having 3 or 4. This is in multiple hospitals in the city. We went out to think of how can we reduce Candida auris. And one of the things we did was to think of one hand hygiene improvement. We found that hand hygiene is particularly poor. In some units, it's about 30%, particularly amongst doctors, which is very unfortunate. So if you're a doctor, they're listening to me, go wash your hands. Then the next thing was environmental hygiene. Whenever we walk into a hospital, the concern is usually the dustbin and the floor. But remember, for a patient lying in a bed, the environment is that bed, it's a drip stand. If they're in ICU, it's a ventilator, it's a monitor. And we're actually systematically reviewing effectiveness of environmental cleaning. And it's interesting, we use something called glow jam, which is an invisible powder. You apply it on surfaces around a patient's bed. And then you come with a torch and a certain light that we use. And if it's still there, then it lights up luminous blue. And what we do is let's say an ICU bed, we'll apply it on the bed rails, the monitor, the drip stand, all the things that, the healthcare staff and the patient will frequently touch. And it's interesting that in many facilities, even 5 days after applying blue gel, effectiveness of cleaning is still about 0%, which means you come, we've cleaned the floor, we've looked at any rubbish, but we've not thought about actually cleaning that patient's environment. And that's one of the things that we're really working on right now, around how do we improve environmental cleaning in the hospital, because environmental hygiene will be very key in preventing transmission of resistance. So as I come towards the end, I really like this diagram. I think it's one of the things I talk about several times in a year. We really have to think about how do we use antibiotics. What are the things that as a healthcare worker we should think about? One, does the patient have an infection? So many times a patient will come with fever, headache, I'm feeling weak, and often they will go out to the casualty with an antibiotic. Chances are, we've seen our prevalence of antibiotic use in this country in multiple facilities in the country. So the first thing people should ask, does the patient have an infection? And the way to do this is to really go through proper history, proper physical examination, and relevant investigation. Thinking about, am I taking the correct samples at the right time? Am I taking the right way? Am I delivering them to the lab in time? Okay. So does the patient have an infection? And if it's an infection, yes, I think my patient has an infection. Is it a bacterial infection? Because as we saw earlier, most infections are viral. Most patients come because of a respiratory tract infection, and most of those tend to be viral. Many patients come with mild and self-limiting infections, and many of those are self-limiting, do not require antibiotics. So that has to be a question that you constantly ask. The next one is, have we ordered appropriate cultures? So you're meeting a patient in their facility. You want to start an antibiotic because you think they have an infection that requires an antibiotic. Have we taken appropriate cultures? Have we taken a blood culture if you think a patient has a BSI or a pneumonia? Have you taken an appropriately collected urinary sample if you think your patient has a UTI? Have you taken CSF if you think your patient has a CNS infection? And then the issue of empiric therapy then comes in. And empiric therapy, we should really be determined by our lab data. And I'll show you, for example, how we developed guidelines, for example, for the KNH National Hospital, using our lab data. And once we start this empiric therapy, you have, and your lab results come, your patient ever have an infection? If not, stop the antibiotic. My patient has a pneumonia. It's been 5 days of an antibiotic. My patient is better. Stop the antibiotic. Or I started my patient on treatment for bloodstream infection. I started them on ceftazidime because they've been in hospital, and now it's come back, it's an E. coli, it's susceptible to cefuroxime. De-escalate. Okay, so we really always have to think about stop if there's no infection, de-escalate or narrow the spectrum if your bag is susceptible, stop if you've given it for a sufficient duration. And the question of duration is an important one, and it's a very low-hanging fruit for many antimicrobial stewardship programs. If someone has a cystitis and you want to treat it, female with a cystitis, treat for 3 days, Someone has a community-acquired pneumonia, treat for 5 days. Someone has a meningitis, treat for 10 days, so that you're not giving antibiotics for 10, 14, 21 days and just renewing tissues without thinking about it. This is an example of a treatment history that I took from a patient when we asked to see. So this patient was being managed for infective endocarditis. So they came in with fever, they were sick, they were started empirically on some antibiotics, and it evolved over time. As you can imagine, infective endocarditis does not go away in 1 day. Often a patient may have a longer course, and we treat this for longer. Often it will be about 4 to 6 weeks, depending on the organism that you're isolating. So this is a patient who started on cefepime, was given azithromycin at some point because of spot and the community-acquired pneumonia. Flucloxacillin was added at some point because there was a staph. Gentamicin, vancomycin, and all those were happening in the space of about just over 3 or so weeks. But it's because we are not stopping to think about those 4 moments. What am I treating? Where is the focus of my infection? Do I have appropriate cultures? What are my culture results? what is an appropriate antibiotic. So we're not just changing and adding and changing and adding, which is often happens, particularly in critically ill patients who may be ill for many reasons other than just an infection. A few more things on stewardship that we always have to think about. One, the correct antibiotic, as we said, correct timing and correct dose. And we talked about this when we were mentioning what determines patient outcomes. So one, we need to have our lab data so that we can begin to determine what the appropriate empiric choices for the facility are. Giving an appropriate empiric choice that is informed by your antibiogram increases the chances that a patient that you're seeing will be on an appropriate empiric antibiotic. So we always have to think about how we collate our lab data so that we can have an idea of what to treat. If we delay or if we start an inadequate antibiotic, such as in this case, for BSI, the odds of mortality are 1.5, 50% higher chance of dying. If it's an antibiotic resistant bug and you start on the wrong antibiotic, again, your odds are higher than 1. So we always have to think about how do we inform our empiric choices using our lab data. This is one of our antibiogram for some of our UTIs in KNH, and I just picked part of it. So one, E. coli is the most common organism that we isolate, whether it's in the medical, outpatient, in surgical units, and critical care units. And in the subsequent bars, we're giving sort of the susceptibility to the same. Okay. So one, if a patient has a cystitis without features of an ascending infection, then our preferred choice is nitrofurantoin, because our susceptibility is good, it has good urinary concentration, and for cystitis, that will be appropriate. If a patient has an ascending UTI, so a patient who comes with pyelonephritis, then a good choice would be amikacin, because again, good urinary penetration, and we have good susceptibility. So going through that, that's how we start to think, what antibiotic am I going to use and why? And that's what informs some of the guidelines that we have developed. If it's a patient who's outpatient and unable to tolerate, then we again look at this and say, for which one do we have better susceptibilities that we can use? As we talked about emergence of AMR, as we have more AMR emerging, then our choices are being narrowed, they are being suffocated, and the air is going out slowly, and we have to think about how to reduce resistance so that we have better choices for treatment of our patients. Okay. The other thing is about ensuring we give timely antibiotics. And what this shows is sort of the adjusted odds of death with every hour delay in antibiotic administration. And you see that if you delay by about 5 to 6 hours, the odds of death are about 2. So we always have to think about how do we give patients antibiotics at the right time without undue delay. Okay, and then you also need to make sure you have optimal management. And whenever I present this, it looks like I'm marketing infectious disease. But where you're unsure, consult, call someone, have someone come and see that patient. Because when we have the appropriate person managing a patient, then outcomes are better. But you also have to make sure you work up your patient. I think the common trend that we see is that a patient has fever today, and as we said here from our PPSs, we started on ceftriaxone, right? Because that's what we've been doing, and that's what now we make sure we're not doing. Then after 2 days, they still have low-grade fever, they change to something else. After 3 days, low-grade fever, something else is added. So in a span of a week, a patient has been on multiple different antibiotics or combinations of antibiotics that are not appropriate. But what we want is that every time your patient is not improving or worsening, stop, take a step back, redo the history, re-examine your patient so that you make sure that one, is my patient not improving because of an infection, or could they have a DVT? Could they be in pulmonary edema? You know, there are many other reasons for patients not to improve, so that we're treating patients appropriately, not throwing antibiotics at patients. Okay, so just to finish, there are a number of useful resources. Many of these are available on the Ministry of Health website around antimicrobial use, around diagnostic stewardship. Next week, we're launching the KNH guidelines for surgical prophylaxis, as well as empiric antibiotic guidelines, and also the WHO website. I'm proud of this, it was part of the team that wrote it. the antibiotic handbook for both outpatient and inpatient infections. It's a very, very excellent resource that you can access it on the WHO website. So use these resources for appropriate prescribing. Thank you very much, Dr. Mario.
So thank you again. I think it has a better app.
People online, you better be clapping. We can't hear you.
All right. Like I said, someone talks very fast. So if you miss something. So we have 2 questions for you. Is there any question on the floor first? So you take up the online questions. There are 4 questions. The first question is, thanks Dr. Alois for a good presentation. My question is, how do you control over-counter antibiotics? I think you're contributing more to resistance and again, causing danger out there. Another question, we have been using anti-TB drugs for so long. I have seen more resistance of RIF. Is there a plan as a country to consider changing first line of anti-TB drugs? Could the new anti-TB drug and treatment failure be because of that?
Okay.
You can talk.
Okay, all right, thank you. I think for the first question, that's a very apt observation. The bulk of antibiotic use, actually the bulk of antibiotic use is in animals. So of course we need to have a One Health approach so that we're also using, reducing antibiotic use in the veterinary service. In human health, again, the bulk is in the outpatient. And the issues of how do we reduce over-the-counter prescribing is a difficult one. So one, there has to be a policy level decision. And I know from PPB, there is some restriction to antibiotics that no one ever enforces, but that should be a key step. There has to be enforcement. We have to get to a point where you can't walk to a pharmacy and get an antibiotic. And I'll tell you, I was once in the US and I walked to a pharmacy because I was feeling really unwell, and it's very bad to be sick when you're away from home. And I knew what I had and what I needed. And I mean, the pharmacist said, no, you have to come back. And I thought, I'm an ID specialist. I said, I know, doc, I'm so sorry, but I can't give you without a prescription. So she told me I had to go see a doctor. So I looked for a doctor who was nearby and I told him, okay, this is the thing, this is it, prescribe this. And I mean, we just chatted and he prescribed what I was telling him because we knew what it was. But I had to go and see him to get it, to go back to the pharmacy to have a prescription. So we probably need to work towards that point. I know in our context, the argument is often that, oh, access to doctors, or people will die because they don't have access. But the truth is, majority of the infections that take people to pharmacy are not bacterial infections. So I think that's something that we have to think about. The other thing is around educating our patients. Patients often demand antibiotics, so we have to educate them. A patient will come to you, and if you don't prescribe, they'll go to the next one and they'll go to the next one, but because they do not understand. So let's make patient education our responsibility. We probably should include things around stewardship in primary school curriculum so that children know and tell their parents they shouldn't take antibiotics. When you talk about anti-TBs, yes, the issue of drug-resistant TB is increasing, and there are many newer regimens that are also shorter regimens for drug-resistant TB. Rifampicin still remains a very core antibiotic, antimicrobacterial in the treatment of TB. And one of the things we have to think about, in many contexts, I've seen a lot of patients on rifampicin for brucellosis or substrate infection. We have to protect our antibiotics for what they're critical for. So one, use them only when necessary, and in our context, it really should just be in the context of TB infection. But now there are many newer regimens, and actually the WHO has released recent guidelines for some of the shorter TB regimens, even for drug-resistant TB, that are on the website and are available as a resource.
The third question someone has asked, there is a certain campaign, I think she saw about Avenue with a lot of expired antibiotics being dumped, in the landfills and all that. Is there any way to help this? Because will TB be a big area where resistance will develop?
So that's an important point, and I'm hoping Dr. Yakinson can talk about how to appropriately discard expired drugs or any drugs that we need to discard. When we dump antibiotics in water, in sewage, and the rest, then remember we live in one ecosystem. The water goes around, it's taken by the animals, it's used by humans. So there's no one sector that you can dump antibiotics in and expect that the rest will be safe. So I think the question of how to appropriately discard expired antibiotics is an important one and should be followed appropriately, because dumping in water is really just then taking the same antibiotics at the tail end of that water purification process. Yeah, I'm not sure I have a very good answer, but maybe the pharmacists will talk about how best to appropriately discard and what support is there for those who may need to discard antibiotics.
Okay, any questions from the floor? If there's no question, we'll give one person to ask a question.
Invite we just to say thank you for a wonderful presentation. For questions, I didn't have any. Thank you.
All right, thank you.
So a big hand of applause for Dr. Thank you so much, Dr. You can invite the next speaker.
Who's the
Professor.
The next speaker. Okay. So it's my pleasure to invite my teacher. I know problematics of microbiology idea. So it's my pleasure to invite Professor Revati, a very eminent microbiologist and teacher by excellence, to give us the next talk. Welcome, Prof.
Thank you, guys. You really make my morning. That was a wonderful presentation. And also it's my deepest pleasure to be on the same forum with my own student, who's a successful, very eminent ID specialist. And that WHO book, which she showed, she's a contributor in that book. So that is the impact. So you can imagine my pleasure this morning. Thank you, Dr. Amaya, the organizers, for giving me this lovely opportunity this morning. Let them open my presentation. What I'm asked to do in a series of 3 presentations is over 20 minutes to show data. Now, this data is a big thing. Always we are lamenting that we don't have data. We need data for action, right? You need some information. You need to go and gather. You have a data source. First of all, you need to have the source, and from the source you gather the data. You collect it, you collate it, you analyze it in a proper way that it is useful. And now after analyzing, you understand and interpret the data. And after that, this is a process. Yeah? And it has to be a standardized process, meeting all the quality requirements. And after this process, now you have summary of the data based on which now you plan action. Okay. Now we have what is called a National Action Plan for Kenya. We have Global Action Plan for AMR mitigation, and also action plans for implementing antimicrobial stewardship as one of the ways to control antimicrobial resistance. So far, all these plans have been plans, and how much action has been taken, I don't want to elaborate. You can imagine, you can see some action is being taken, but how much action is actually being taken, we are not really sure. Are we on the presentation? Start from here. I move from this. Okay, so the time is now that it has been realized a lot of action plans have been made, but the plans are plans on paper, but action needs funding, right? And resources. So unless you have funding and resources, you will only keep the plans on the paper. That being the case, recently, I must share with you before this presentation opens. Recently, there was a forum called Global Leaders Group on AMR. Now, who are these Global Leaders Group? They are about 68 countries, prime ministers, presidents, and the president or prime minister's representative. If I ask somebody I nominate as my representative, I am the president, that one is equally powerful, like the president, my nominee. So that group has presidents, prime ministers, and nominees of the head of states, and they all met in Copenhagen last month in April, and they made some decisions. Because it is such a powerful global group. All countries are sitting on that low income, high income, middle income, all countries are represented there, and many more are joining. So this group has demanded the World Bank and the world leadership that these action plans must be funded and well funded, so that now we translate all these plans into action. Can it open now? You have to give me extra time. Technical problems. So now the time has come, we will be funded for these plans. Now, when we are funded, we need some baseline data. So what kind of data should be used? Why do we need data first of all? The AMR data is a misnomer. We should call it antibiotic susceptibility data. Don't call AMR. Don't say AMR training. Say basic microbiology training. That is the correct word. But unfortunately, unless you use the word AMR, you will not be taken seriously. So globally, even the specialists who know that this is a misnomer, they still use the name AMR. So this is called AMR training. If we call it internal medicine training or infectious disease training or stewardship training, it's not very impressive unless the first word is AMR. So we have to fall in line. Most of the time that is necessary, we have to fall in line. Those are my credentials. I have no conflicts of interest. Quickly to share with you my institution, Aga Khan University Hospital. Lot of you have seen. That is the Pavilion Garden. That is the hospital. This is the ICU. Why do I show you ICU? This is the Shamba of AMR bugs. Lot of broad spectrum antibiotics, amikacin, meropenem, tazopiprid, what have you. Now we are also using ceftazidime avibactam, which is a new antibiotic. We can't minimize this. That's better. Okay. This is quickly to share with you the isolation room in our ICU. This isolation room is to keep one patient completely isolated, the one who has MDR bug. Yeah, keep him isolated and then nurse him separately so that there is no infection spread. So you find there is a rack there which is empty. Do you see the rack which is empty? This rack is empty. This is to illustrate the problems. You are in a low income, middle income setting. Whatever you do, this is a high-end JCI accredited hospital. But that rack is empty because that rack is supposed to contain the supplies, the gowns, the gloves, and the masks, caps, and all those things, but they were getting stolen. So they had to keep them under lock and key. That beats the purpose, right? Of course, there were interventions done. That is not the situation now. All those things are taken care of. But just to share with you the issues in low resource countries, they remain. Whatever you do, the environment where you are, you can't go beyond that. But we have to struggle and reach there. This is bacteriology lab. Quickly, these are the outline. Anyway, I'm going through, so I don't want to dwell on this. 1966, 1967, the Surgeon General in US said that we have wiped out all infectious diseases because we have antibiotics. Okay, not long ago, 67. Now, this is an economist, Ramanan Lakshmi Narayan, the director of CDEP. Now it is called One Health Trust. And his book is actually very scary. The economic downturn and what happens when the AMR is not controlled. This is the Global Leader Forum, 2017, One Health. The water, soil, everything Dr. Lois was telling us just now about the environment. Like discard antibiotics, if you discard them anywhere, they will dissolve in water, they will reach your river. From river, they reach the sea. So they are saying you should incinerate the antibiotics before you discard them. We don't have incinerators for clinical waste. How are you going to get incinerators for antibiotics? Very difficult, right? Hospitals are struggling to get an incinerator to get rid of the clinical waste, right? We still take it to dumping. So those are the issues, that is the reality. So that is One Health. This is reality we are seeing. The environmental degradation has far-reaching impact on AMR. The disparity between the low-income and high-income countries has been highlighted just this year, 2 years ago. Inequity, LMICs and HIC funding in research, in support, budgetary support, and even the knowledge sharing, intellectual property, everything is a big problem. The high-income countries are again doing something called pseudo-colonization now in the name of global health. Every university has a global health department in the US. In that department, people are all over the globe. They are capturing all the data. I don't know the data in Kisumu, which is coming out of an international project, but the data is in Atlanta. Okay, so that is what we are facing. It has implications. Low resource countries, antimicrobial resistance surveillance, what are the problems? There are a lot of problems. And these books, Dr. Lois has already shown us. These are the national documents. They are all on the website. Action plans, lot of plans. And this is from WHO and the donors, UK, US, Canada. WHO is funded by all of them. Bill Gates, Melinda Gates Foundation, WASH. This is a very good treatise. Situation analysis in Kenya. Okay, now data. Quickly, I want to show you some data. The data internationally, globally, it is available. Lot of data is available. We don't know that the data was there in Kenya, but you will find it on the international website. Lot of them are there. I'm only showing you one example. This is from a UK university. It is an interactive website. You can just, it's an open, you can just log in Google and you go there and you move the cursor. And when you move the cursor, you can go to any country on the map. On the left side, you can choose the years from 2017, 18, 20, 21, like that, up to 22. The data is there. You see on the scale here. Let me bring the laser. Yeah, this is the scale. From here to here, you can choose any point, and then you choose a country, and then you click, and you will get the data for that country. And how does it look like? This is how. Country Kenya. I'm just showing you that. Year 2000, antibiotic consumption 17.6 and uncertainty interval 17 to 18.3. That is the range, but 17.6 is the antibiotic consumption in 2000. And then another point you choose 2018, same Kenya, and you show antibiotic consumption 14.4. It has decreased. Okay, we are doing very well, guys. Nobody is telling us. They keep saying that your situation is very bad. You are doing this, you are doing that. You don't have systems, but we reduce the consumption. But what are the reasons? If you look at the reasons, we don't know whether they are good reasons or bad reasons. Maybe because we couldn't afford the drugs. Dr. Amaya was sharing something with me yesterday. Maybe we couldn't afford, that's why we are not using. And maybe patients died because they didn't have antibiotics, right? So that is an international data. Now come to Africa. This is regional data, okay? Global data, I gave you only one example. There are so many websites. They all have data because they are global health partners. They have money and they have collected data. Now, is that data helpful to us? What I showed you just now, will it help you? You have to think really. Now, this is a regional data, African data, recently concluded project called MAP. And I scroll through, you can just access it, free website, Google it and you will reach there and you can actually explore and look at what it is. I want to show you only quickly salient features because of the time constraint. Look at these numbers. These are the reports they reviewed, so many. Then these were their lofty objectives. And then these are the countries, 14 countries were involved in this data collection. And then this is the breakup, how many reference labs, how many low level, middle level, primary health, level 2, all those statistics. And this is actually the countries and the resources. Look at Kenya. This is Kenya. Blue is laboratory interventions, very small, hardly you can see. But these are other interventions. Total number of interventions means medicines, this and that. Yeah, theaters, dialysis machines, so many things, ventilators. But this is laboratory intervention. We have ICUs. Patients are on ventilators, but there is no blood culture. Go to any county referral hospital. How do you maintain a patient in ICU without blood culture? You are nothing short of a herbalist or a magician. What Dr. Lois was showing, you de-escalate when you have a report. But if there is no microbiology lab, which report are we talking about? There's nothing to look forward to. So you continue meropenem, tazopiprid, amikacin, change to metronidazole, it goes like that. So if you ask him to stop antibiotic, there's no report. If the report comes, you will stop. There is no report. What will you do, Dr. Adil? Dr. Adil is our ID specialist. What will he do if there is no microbiology? Yes, he can do so much with knowledge, but there is a cap there. Okay, this is now the data. Pseudomonas, I'm just showing you two examples here because of time constraints. Pseudomonas CRE, meropenem resistance, 25 to 40%. This is aggregate, all 14 countries. And look at priority, Pseudomonas is critical. And in 88 countries, 25 to 40%. And they have suggested these interventions to get rid of it. We know all of them. There's nothing new. Yeah, we have been doing all this. This is now Enterobacteriaceae, Klebsiella, E. coli. Priority critical, less than 25% CRE in most countries. And these are the drivers, combinations. This is the drug and these are the organisms. Okay. And this website gives you all this data. Only thing, how do you use it? Look at this slide. This is talking about the countries and resistance drug bug combinations, and they calculate it like what is called a drug resistance index. And the index is at 50, that means 50% resistance. The drug you cannot use empirically in 50% of the patients. It's likely to fail. That's a very serious condition. Okay, so that's what this data tells us. But beyond that, how to manage your patient in such and such a hospital with such and such a condition, unless you have that lab report or X-ray or ultrasound, some diagnostic support, you are not likely to control antibiotics. So that was map data for us. I think I will skip all this. Then a lot of things appeared. These are the infographics of the same data. I skip all that. Now we come to Kenya, Kenyan data. This is our Ministry of Health website, One Health website. It's called AMR dashboard. Okay. And this dashboard is fantastic. Look at it. It is giving you 613 samples and it gives you the breakup and it gives you the locations and it gives you lots of things. I won't go into each detail, but you can access it. And it has all these, every organism, and it has locations. It is a fantastic tool. It has a location logic. You can say Machakos, Thika, or whatever centers which are contributing the data. Now the data into this platform is coming through 8 AMR Sentinel surveillance centers under Ministry of Health, and also another 8 or 9 veterinary centers. All the data is collated. You can click and get aggregated data, human data separately, animal data separately, like you can say blood culture, wound swab, this and that, Pseudomonas, Acinetobacter, organism wise, sample wise, antibiotic wise, all that it will do. But how do you use this data? Resistance, intermediate, and susceptible. This is now for Klebsiella pneumoniae. It is giving you the sample breakup. It is also giving you the percentage susceptibility. Okay? But think, how do you use this data? For big policy, yes. But if you have a patient on your hand, will it really help? Think about it. Try to understand. Now, it is showing all the antibiotics here. This is the locations. All these are locations, contributing centers. I think I will quickly skip. This is general summary. Some other graphs. I'm just showing you examples of what all it can do. It can do graphical, line diagrams, histograms, pie charts, so many things it can do. This is another example. This is animal specimen type distribution by county this year. Okay. And then One Health Aware dashboard. Now this Aware analyzes amoxil, access antibiotic, restricted antibiotic, watch antibiotic classes. You click and you can get the data. Little bit of training is required how to extract the data. So I skip all this because now this is location logic and this is a pie chart, typical pie chart. And this is again Acinetobacter baumannii. Let me skip this. I come to facility level data. How much time I have, Dr. Maya? For this presentation, data. Okay, so we can club both continuously. Thank you, because I don't want to go over time. It's interesting though, but people may. Okay, now we have seen global data, we have seen regional data, Africa level data, and we have seen Kenyan national data. Now I come down to my facility. Okay, facility level data is again very tricky. This is our antibiotic guidelines, which are revised. They are printed by pharmacy, they are distributed, and always there is a clamor that the book is big, it should be small, it should be in the pocket. How often do you use it, doctor? He will tell us. Microbiology spectrum and susceptibility. This is how one of the examples, right? And then how does the data come? Now, sorry about this, I couldn't edit these slides. Various data we check and we support the ID physicians. This data is from a machine called BioFire. BioFire is a molecular platform. All of you know, pretty expensive. Each patient has to pay 35,000 for one sample. So we have a respiratory panel, we have a GI panel, we also have blood culture panel, meningoencephalitis panel, so on and so on. So that machine does a beautiful thing of analyzing trends. So you see, these are all the viruses and pathogens. Each one is coded with a color, and the colors will give you the trend. And this is the timeline. Every month you can see, every week if you want, you can do the software is able to do it, you click and you do it. So these trends are very helpful. One more, BioFire syndromic trends, respiratory pathogens. The previous one also, respiratory pathogens. And this is gastrointestinal pathogens. You see which is the virus, which is the bacteria, and it is very, very helpful to support the ID physician, but only during that time. Because you see the trends are changing. If I look at the trends 2 months ago, the trend has changed. I can't use that. So you need real-time data. So this data is a double-edged sword. It can cut you both ways. Who is using it, how he is using it is very, very important. You have to be trained how to use a single-edged sword, how to use a double-edged sword, how to use a long sword, a short one, and depending on how trained, well-trained you are, you can use that weapon very well. So these are the trends, gastrointestinal pathogens. Now, this is how Aga Khan data is usually collated. This is blood culture, ICU, outpatient, and the ward. You analyze location. ICU, very sick patients. Outpatient, ambulatory patients, and ward. But we have to understand this OPD, seriously sick patients. Blood was collected before the antibiotic shot, then they got admitted. So actually these two will be the same, but this is community bacteremia because before antibiotic, at the time of admission, even when the file is being prepared, a number was being given, this blood culture was drawn. Okay, and the same guy goes and gets admitted to ICU, wards here. So separating them like this is only logistic. But if you look at the file and you look at the location of the patient, all these are sick patients most of the time. Okay. The other thing about blood culture, which is contaminant and which is pathogen, it's very, very important. This cannot be left to the lab tech. If you see KNH data, all the skin contaminants appear on the data because lab techs are independently releasing the reports. So those are the limitations we have. This is another table, aggregative urine data. It gives you the pathogen, the time, and the percentage susceptibility against each agent. Now, this can support guidelines, provided it is properly stratified. Who is a patient who is chronic care should be removed. A chronic care patient has already received lots of antibiotics, and hospital data anyway has certain limitations. I'll share with you just now. This is another piece of data, which is blood culture and pathogens which are community acquired. That is, before 48 hours of admission, look at the agents, look at the percentages. This is very helpful to formulate empiric antibiotic choice. This can inform actually the guideline preparation. This is hospitalized patients after 48 hours, Candida is top. Whereas in the previous, E. coli is the top. It makes a difference, right? How you are treating a patient, how your guideline can modify, it can inform the doctor how to manage the patient, which antibiotic to start. So you need very granular, very well analyzed facility level data to be able to inform the guideline committee. Otherwise, all we saw global data, it cannot really inform the guideline. It can inform the big policies and also give you some insights. So this is blood culture. And now this is again showing community acquired, hospital acquired, the percentages and the agents together. E. coli, Candida, Klebsiella, which is the top, which is the next, which is the next. But with all this knowledge, can you confidently start a patient on an antibiotic? You don't know what is in the blood culture. So what is the rule? You must do that blood culture. If you don't have a facility to do that blood culture, how will you de-escalate the antibiotic? You will start broad spectrum. But if you don't have blood culture, if you can't do CRP, if you can't do that X-ray, whether it is pneumonia or it is intra-abdominal collection, you don't drain that collection. How will you de-escalate? Patient will continue to run fever. So diagnostics is very, very important. So some more data on the enterococcus, we are comparing it with developed countries. This is another chart from Sentry, another surveillance platform, and it is free online source. And this is our published data, susceptibilities of gram-negative organisms, which is publicly available. And these are the trends. This is how trends analysis can be done between year to year, between agent to agent, and between sample to sample, organism to organism, you can analyze. So I think I'll quickly go over these things. This is how they look like. We don't have to go into the details. Various charts, Pseudomonas blood culture, urine culture. Now, these are the limitations. These samples are randomly selected. A doctor chooses to do blood culture, another one, even blood culture is available. Everybody doesn't believe. He says, this report is coming after 5 days. I don't care. I want to manage my patient. I have experience. I'm an expert. So he doesn't do blood culture. So when you aggregate the blood culture data, are we sure that we have all the pathogens and the proportions properly? Because everybody did not get a blood culture done. So how do we know when we aggregate this data? So that's a limitation, right? Unless we go and do a prospective study where you get every patient with fever, you do a blood culture, you know the whole picture. Otherwise, you only know part of the picture, right? Not the whole picture. So these are the limitations. Lack of clinical information. Sometimes the patient comes, gets discharged. Aga Khan is very expensive, and he goes away to KNH, Nairobi West, or Avenue, somewhere he goes away, and we don't have the full information. I know I have grown candida from that blood culture, but I don't know the background. Sometimes whether it is a contaminant, we are unable to decide if you don't have the clinical information, right? Patient has endocarditis, there is coagulase negative staph. But if he got discharged and went, I will write this is a contaminant, but it was a pathogen. It was actually forming vegetations on the heart valve, right? So if you don't have that information, you don't have the full picture. I'm showing you where the gaps are in that beautiful picture of all those charts, right? So many charts we have seen. Standardized sample collection. The samples are collected in the emergency. So there is aerobic spore bearer, coagulase negative staph, so many things grow. Maybe they are contaminants. Quality control, is it there all over the hospital? Yes, Aga Khan, proudly I say, is a JCIA accredited hospital. Quality control at every step is there. But is it there in all hospitals which generate a facility level antibiogram? Good question. Duplicates, multiple isolates. We have a method to remove them. We remove all duplicate isolates. Quantitative data, direction only on the broad trends. You don't have, again, you have to do a prospective study. What is the effect of these limitations? Very likely overestimated prevalence. Yes, if you see the urine chart, if you are sitting in the OPD, you want to prescribe and you want to base your decision on that chart, it says 70% of E. coli are resistant to ciprofloxacin. 55% are resistant to augmentin. Why? Because these are all high-end patients, chronic care. They are still seen in the outpatient setting. And the computer brings them to the outpatient data. Okay? But these guys were discharged last week. And they were on amikacin, tazopicryl, and everything. So the resistance is exaggerated. So what should we do? We should still do the file review and sift the data, filter the data without hospitalization, community. So we are not doing it. This is just hospital data, right? So you need prospective studies. Thank you. That is the data presentation. You want me to go ahead with the same or you will take questions? I hope
One
it was
question.
sort of useful. A lot of graphs, a lot of charts.
So you have 4 minutes you've saved.
Very good. Because you know those charts we can talk about them, but not really, just examples to understand the point. Thank you very much. That is the elephant god. That's an invocation. Elephant god to remove all obstacles. We pray first. That was supposed to be the first slide, but it came in between. It's okay. Yeah? And prayer scientifically has salutary effects. It's now scientific studies have proved that prayer is good for health. Anytime, anywhere, if you pray, it's good for health. Reduces hypertension and it reduces hyperglycemia. This is nothing, no, not a new information, right? We all know it. Okay, so AMS implementation in private sector. That's what Dr. Amaya asked me to talk about. What are the difficulties in implementing AMS in private sector? Okay, no conflicts of interest. This is Aga Khan University Hospital. That is the University College, a beautiful resource. You should see our library. Definitely you'll be impressed. Admissions are going on for MBCHB class now. Again, it's not coming.
I'm not shared.
Huh?
Let me share.
Environmental degradation. And we recently learned, it's now on the WHO website, there is going to be eat less meat campaign. WHO is launching because finally, after all the scientific studies, we realized that it is the meat production which is the culprit, not the aeroplanes, the petrol,
and the smoke and the fumes, they said air travel has depleted ozone. All that is not true. It is the animal husbandry all over the globe that is for meat production, which is behind the greenhouse gases. Huge amounts of methane are produced by the livestock, the poultry, and the, what are they called, the where you grow the pigs, hogs. They are massive producers of methane that has depleted the ozone. And now the global warming, and from here we have gone here. Where is this laser? Let me bring it. Yeah, this is green, and now here we are. Okay. This is a Moto report, extensively drug resistance in Shigella flexneri, and also I think it was another Shigella which also acquired the same plasmid. Now, where is this data from? This is from UK. Okay. Now, UK is a high-resourced country, though they are not really. It is only a sham. They are broke as we are, even less broke, or more. So they have a very good surveillance system. All the same, they are still maintaining it with a lot of expense. So this is from UK, and they have done a retrospective study. They analyzed all their Shigella isolates, and they find it is an extensively drug-resistant Shigella flexneri. And also they have other Shigellas which are Sonai. Shigella Sonai is another serotype. It acquired this plasmid, and it is also extensively drug-resistant. Now, most of these produced dysentery. Dysentery is bloody diarrhea. Patients can actually get admitted, not just dehydration, with gram-negative sepsis. If it is a child or an elderly person with diabetes or long COVID, these days there's a lot of long COVID in UK, all over, immunosuppressed population, they will be admitted to ICU. So this is from UK. Now, do we have it in Kenya? Thank God, no. So far, we have not seen it in our labs. Maybe it is there because there are how many flights to Heathrow from Nairobi? So when so much travel is taking place, all flights are full. London, Nairobi, they're all full. So this Shigella can come to Nairobi very fast. But can we detect it? UK produced it, but will transport or export it to Kenya. And do we have the lab capacity to detect it? Sadly, no. It is only few hospitals, Nairobi Hospital, Aga Khan, Mombasa, Kisumu, a few hospitals, private hospitals, they can detect, others cannot. So do you see the situation? They keep saying that everything came from Africa and from New Delhi and Malaysia. No, this one is coming from UK. Maybe it is already there in Nairobi. So this is very serious. Please recognize this. Diagnostics are very, very important. Okay. If we don't have diagnostics, if you cannot do stool culture, if you cannot isolate, you don't have the capacity to pick that Shigella and do a serotype, which is a process, a training and a capacity, mental and skill. If you don't have that capacity, we can't recognize Shigella. You won't know that this UK strain has already come to Nairobi. Tomorrow they will say that Nairobi has exported this Shigella, because CDC will come and do some surveillance. But can we catch it in our patients? Sadly, no. So diagnostics are very, very important for universal health coverage, antimicrobial resistance, surveillance, and global health security. Which global health security? Anthrax, brucella, TB, all these they can be weaponized for bioterrorism, any of the viruses. So if we don't have lab capacity, how can we say that we have those security things? They remain on the paper, on the shelf in our ministries. They won't be available to the public. Lancet's Commission on Diagnostics. There is a paper, I think that slide is missing. That global health, yeah? Global Health Lancet Commission says that 47% of global population don't have access to diagnostics. 47 is almost 50. Yeah? 50% of population can access diagnostics. 50% of the population globally cannot access, zero access to diagnostics. So that being the case, when they get sick, they just get antibiotic. There will be no stewardship. Is it possible? No. Diagnostics doesn't mean lab. It also means basic radiology. Some simple ultrasound, X-ray, something. Stewardship programs in resource-constrained environments, understanding and addressing the need of systems. Now, all these are, I have shown you earlier, the global health partners are writing these papers. They come for 3 months, they go to Masai Mara, then they collect some data from other hospitals and they generate this. Yes, it is helpful because we are unable to do it. We don't have the resources and they give us this wisdom. So we read this. Antibiotic stewardship is the coordinated effort. Now, I want to share with you. Everybody has an impression that antibiotic stewardship is don't use antibiotic, stop that prescription, don't dispense antibiotics, don't use broad spectrum antibiotic, stop it after 3 days, stop it after 1 day. That is stewardship. That is a very big misunderstanding. That is not antibiotic stewardship. What is antibiotic stewardship? Antibiotic stewardship is the coordinated effort and activity that seeks to measure and improve how antibiotics are prescribed by clinicians and how they are used by the patient. Okay? It is using the right agent, the right dose, the right schedule, the right duration, and stop at the right time. That is stewardship. So it may be stopping antibiotic, reducing the spectrum sometimes. It may be starting an antibiotic, escalating to broader spectrum in another situation. Okay? It may be reduce the duration in one situation like outpatient urinary tract infection. The steward will ask you to reduce it to 3 days. The same steward will tell you, if you have a patient with osteomyelitis, please continue the antibiotic minimum 6 weeks. Ideally 8 weeks or 10 weeks or 12 weeks, depending on the X-ray. But if you don't have that X-ray, how you are going to do this is an open question. Yeah, I don't dare to answer that question. Improving antibiotic prescription is critical. Why? Effectively treat the infection successfully, protect the patient from harmful toxic effects, untoward effect caused by unnecessary antibiotic use, and combat resistance. Okay, all these are the objectives or goals of stewardship. It's not just to ask people, don't use antibiotic, reduce antibiotic. Okay, here I want to share with you a paradox. Recent CDC publication, I have given the reference there. These slides can be availed to everybody. A whopping 211 million outpatient antibiotic prescriptions were given out in 2021 in the USA. That is peak of COVID, right? There were millions of deaths, COVID, which were taking place at that time. Patients were going, seeking advice from primary care physicians, and 211 million outpatient antibiotic prescriptions were given. They have this data analysis, how much ampicillin, how much erythromycin, azithromycin, all the data is there. This is equivalent of 636 prescriptions for every 1,000 individuals. That's a lot of antibiotic prescriptions. They have all this data. They have the capacity to gather all this data. Why did they do that? Don't they have stewards? Don't they have trained people? Don't they have ID physicians? Don't they have capacity to control antibiotic use? They have everything. They are our gurus. So if US could not control antibiotic prescriptions in 2021 with all their resources, how can you demand, WHO demand Kenya to reach this target, reduce, do this, do that stewardship? Can you just think about it, please? I want all of us to think about this, our own thinking. Yes, we read, but digest that and think. How can Kenya or Uganda, Tanzania, all these countries, there are some which are even low resource, Congo, all these countries, WHO is demanding that implement AMS. We are sending the global health partners. They are coming and training. Right now, as we are talking, there are 6 international partners who have huge funding. They want to implement AMS and train AMS. We don't have labs. We don't have X-ray. We don't have ultrasound. Can they fund that? Perhaps no. Okay. Prescribing rates were widely different from state to state, and there is all that website. If you open that paper, you'll find very interesting data. Let's not go into that. Implementing stewardship program in resource limited settings has a lot of issues because most of these programs are designed in Australia, Canada, US, UK, or Western Europe, France, Germany. So when they design the program there, we are trying to implement it in Kenya. You don't have ID physician, you don't have ID pharmacist, you don't have labs. So how do you implement all these things? It was designed in the high resource country. So think about it. Yeah? Can we really implement? Can we pretend to be implementing? It is easy to implement them in private sector. That is my answer. I was asked, what are the difficulties in implementing in private sector? In fact, it is much easier, Dr. Amaya, and my delegates, respected delegates and all the participants, it is much easier to implement in private sector because there are resources. And once the Ministry of Health gives a decree, a small notice, private hospitals take it very seriously. They are actively, like they engaged some specialists, like Dr. Lois consults, Dr. Budhia consults. I am full-time with a private university. We are under continuous pressure to give the latest information. I go to WHO website. The minute Gene Expert TB was approved, 2012, I had it in my hospital. Okay, yes, later donors rolled it out all over the country. But that's not the case for all other diagnostics, right? Malaria, TB, and HIV were well funded, but still we find because of the donor funding and the requirements of the project, we are not there even in those three conditions. We still have a lot of gaps. So a lot of things are doable in public sector, which are very, very little. What we can do in training, we can do in public sector. But that training implementation in private, it is possible to get the resources. So Joint Commission International, which is accredited, Gertrude Hospital, Dr. Bhutia is here. Aga Khan Hospital, Dr. Adil is here. These hospitals have all those systems in place and they have these tenets. There are 12 elements of antimicrobial stewardship, which are actually written down in the JCIA document. They have to implement, they are audited, there is no way. So it's very easy, I don't say very easy, but much, much easier to implement in private sector. What are the difficulties? Yes, there are some difficulties. Okay, before I come to that, these are the lists of conditions where an ID physician should be consulted according to the lessons, the testaments we get antimicrobial stewardship. So there are some microbiology factors, there are some patient factors, and there are lab results. Okay, these are the agent factors, antimicrobial agents. If it is broad spectrum, if it is colistin, you should consult. You want to use tetracycline, you should consult. If you want to start your patient on ceftazidime, avibactam, you must consult ID. And Aga Khan actually follows this to the letter. And I think Gertrude also follows to the letter. And these are the organisms. If you get an MRSA bacterium, ID should be consulted. So how much this can be done in public sector is very difficult. Now, this is my favorite document, Antimicrobial Stewardship in Australian Healthcare. Why I like this? Because Australia is a high income country, but they are very frugal in expenditure. By the way, the secret, they are also broke now. Kabis are broke. The prices, the inflation is just like Kenya. But this document is very beautiful. And they have taken consensus from UK, US, NIH, everybody globally. They are not parochial. I should just have my Australian cousin on the committee. They take everybody, they consult everybody. Even South African consultants are on this document. It has beautiful chapters. It is free resource. Just Google and get it and read. AMS in dental care, AMS in skin care, in dermatology clinic, this, that, ICU, old age, low resource. And then it has a beautiful chapter on AMS implementation in far off areas, where there are no specialists. There's a primary health center, no specialist, labs may not be available, but they have a very nice referral system. You can still send a culture. So that makes a very good read for high income, middle income, low income. Everybody can read, everybody can implement a few leaves. These are just examples. 9th chapter, role of clinical microbiology service in antimicrobial stewardship. A beautiful chapter for microbiologists. Antimicrobial stewardship in dental practice, chapter 18, just to show you examples. Then it also stipulates what are the AMS standards. They have counted 1, 2, 3, 4 like that. The standards, I don't go into all of them, but just look at standard 1. A patient with life-threatening condition due to a suspected bacterial infection receives prompt antibiotic treatment without waiting for results. Standard number 1. If somebody is waiting, meningitis patient is waiting for an LP kit to be brought and he delays the patient by 1 hour, patient's life is ticking off. So the standard says no. Okay. So they are all antimicrobial stewardship standards. Stewardship is not, don't use antibiotic, switch off antibiotic, de-escalate, and that is not stewardship. This is stewardship. So there are several standards. There are other standards. When a patient is prescribed antibiotic, the reason, the drug name, the dose, route of administration, intended duration, and review plan is documented in the patient's health record. That is a standard. Okay, that is AMS standard. It's not just don't use antibiotics, stop antibiotics. Okay, those are the standards, and against the standards, documentation is done and the facility is audited. So that is what I wanted to share with you. This is integrated stewardship. Have I finished my time? Not yet. 4 minutes. Okay. This is what I wanted to share with you. You cannot do antibiotic stewardship or antimicrobial stewardship alone. It is an integral part of a triangle, which is diagnostic stewardship, IPC stewardship, and antimicrobial stewardship. So that is the triangle. It is an integrated model. All the 3 stewardships have to be integrated. If you have a patient with MDR, there is no infection prevention control stewardship. That is, the steward immediately goes, educates the people, isolates the patient, and then is following and auditing, and then checking if the bug has already spread to other patients, doing some surveillance, educating all the health workers. If that is not happening, that is IPC stewardship. If that is not happening, your antibiotic stewardship alone cannot do the job. Diagnostic stewardship. Quickly, this patient surveillance cultures are done, other surveillance cultures are done, other patients are monitored, and then blood culture is done. And where is the bug? Environmental cultures are done, that is diagnostic stewardship. If that is not an integral part of this stewardship, antimicrobial stewardship is likely to fail. Quickly, what is the role of microbiology? This is the workflow, pre-analytic, analytic, post-analytic parameters of the microbiology laboratory in educating the physicians, advising the physicians what type of tests should be done, for which diseases. These are the priority diseases stipulated by WHO: sepsis, lower respiratory infection, urinary tract, meningitis, typhoid. And these are the bacteriology tests, scales of tests, and these are the critical priority, high priority pathogens. This is the WHO free website. Yeah? Everybody should know this, right? To know the standards. These are the quick, rapid diagnostics available. Why I am showing this? Because this is only available in the private sector. Yes, we have a MALDI-TOF in our National Public Health Lab. We are very proud. It is also available in Nairobi Hospital. It is available in the Walter Reed, and we are getting it in Aga Khan also very soon. Because of the cost, we were balancing. And then these are the rapid diagnostic tools, PCRs. They are expensive. They are available in the private sector. To bring them into the public sector is a challenge. So I will say stewardship is easier in the private sector. It can be implemented. And these are the other tools of rapid diagnosis. Very expensive. Your BioFire is there. It costs 35,000 shillings per patient. And these are the syndromic approach. for doing the stewardship. You can generate one-click information on all these panels of pathogens, which supports the stewardship very beautifully. CLSI guidance for making an antibiogram, which I have shown you. Aga Khan antibiogram is made by the CLSI guidance. This document has to be purchased every year with $200. This is only private sector which is able to do it. Unless the donors give, we can't. This is a private hospital in Delhi. They generate this information, antibiogram, stratified to the clinicians, separately for ICU, for medicine, for cardiology, for neurology. They stratify all neurology, separate antibiogram. And they are able to do it because they have the funding. It's a private university, just like Aga Khan. This is Sir Gangaram University. And this is the guidance. Electronic health record is very essential for easy implementation of stewardship. Without that, if you have manual records, it's very, very challenging. So this is available very easily in private sector. Yes, donors are supporting in public sector also, but it has a lot of issues, license fees, who will pay, telehealth, internet access, staff willingness to embrace technology. And all this is easier implemented in private sector. Now, quickly, clinical acumen. You can have so many things, but if you can't spot what is this condition, what is this condition, you can go and prescribe antibiotics. What is this condition? This is carbuncle. Control the sugar first and hit the Staph aureus. No need to do culture swabs. No need. Do you need? And this is herpes simplex, zoster. Do you need antibiotic? And what is this? Fulminant cellulitis, life-threatening, crystalline penicillin, high doses, doctor, right? Immediately spot the diagnosis. Of course, later you investigate. What is this? Gas gangrene, spot the diagnosis. No culture, immediately you have to crack down on the management. The management is 1, 2, 3, 4, everybody knows. This one is actually healthy wound. No need to do a swab. So I leave you with this. What we choose should be what we actually hoping to do, but not we are scared of. We can be scared of so many things. And then what we are doing should not show that fear and scare, should show our hopes, aspirations, and that we can reach the height, and we should ask the sky, go higher, our targets are higher. Thank you very much.
You have enough time. The case presentation is next. Okay.
So another club. I know Dr. Morata is here. Could you pick out the slides again? Dr. Morata, between herpes and Staph aureus. You left clinical. So we'll move to the next slide, and her next presentation will be on a case of AMR, and then we can go for a break. But we are doing this differently. We will introduce ourselves before the break, right?
Thank you. That would be very nice.
Yes, because when she's talking about private hospitals, most of them are here. I think we have Avenue, the truths. We are waiting for Martha.
That is the first slide.
We are waiting for Martha. We have Jagaram. So I think we're able to say that we can implement, right? She said it's easy, right?
I did not talk about the difficulties. There are some difficulties.
Okay. Remember, if you don't change your environment will change you. So when you go back, the data you're taking is to change the environment. We want to also welcome Dr. in our next speaker. So thank you so much for making it.
So what next?
Case presentation.
I start case presentation.
Yeah.
Okay, let me put. Okay. Thank you, Amai. This place is warm. I'm drinking all the water. Or maybe I'm feeling warmth. Yeah? It's warm. We need some fresh oxygen here. Yeah, we are so sensitive after COVID. Everybody is oxygen. I think they shut off the, you see all the windows are shut, supposed to be air conditioned, but always the air conditioner is switched off because it's cost cutting. Huh? I believe the taxes have increased. So they'll shut all this and then we see it's so warm. Huh? And then this carpet, it will now remove all the spores. Thank you very much. So I have 10 minutes. Roughly 10 minutes. Less or more? Less. 1 minute less. Fine. Okay. This should take only 5 minutes because this is only to stimulate the thinking. It's not that we can do everything here, right? These cases are supposed to stimulate thinking and then make you go and read more, explore more, and teach more, and discuss with your colleagues more. That is the objective. Here we have a 56-year-old woman complains of an ulcer at the back of her right thigh, not healing since 5 to 6 months. Patient consulted various clinics, private sector, public sector. She has gone to like the national hospital. She was there, she was given some antibiotics. And every clinic gave a different antibiotic because she's an educated patient. She says, last time this was what I was given. It is Zenat, Zenacep, something. So the next clinic gives her something else. Oh, Flox, Ciproflox, or Ampiclox, something else, some other name. Yeah. So she has already been given cephalosporins, macrolides, quinolones, and gentamicin shots also before she came to this clinic. Now we are seeing this patient. What are the crucial questions you like to ask in the history? Amaya, to make it interactive, you need more time. But if I just go on talking 5 minutes, I'll finish. If I ask somebody to answer and all that, that takes time. So depending on the time. Okay. So this patient, now you have seen that history. Number one, in history, what are the crucial points you would like to know from this lady? I have only said 56-year-old lady, and this ulcer is there 5 to 6 months back of the thigh. Okay. So Dr. Raja Rao is raising his hand. What are the questions you want to ask? Yes. Speak into the mic. Because online there are 800 people.
Most important question which you would like to ask the patient at this age group is the history of diabetes mellitus. Whether the patient is a chronic diabetic or not. If the patient is a diabetic, then what is the control of diabetes? What is the HbA1c currently? If we
Okay,
have the
I said she is not diabetic. She is not non-diabetic. She is getting her blood sugar done every 6 months.
Secondly, you would like to know if the patient is immunocompromised or not, because this is a non-healing ulcer. Because if the patient is immunocompromised, if the patient is on ARVs, if the patient is on ARVs, what is the current viral load of the patient if we have the values?
Any other question you would like to ask this side? The ladies. One lady. Any other question you want to ask this patient? Yeah, any volunteer?
She had done first stage before.
Yes, excellent, excellent. So, what is the lesson here? The lesson here, that is the ulcer. Now, look at the ulcer. It has been there, for such a long time, 5 to 6 months. Okay. So now you can do a swab. Okay. Now, after listening to all the lectures of stewardship, a doctor says, I should do diagnostics. Let me do a swab. Okay. These teachings, they are also sometimes double-edged sword. Yeah. Sometimes you feel it's better not to teach these things because they are producing the negative effect. So now this doctor was through one of the CMEs like this. He said we should be doing culture. Okay. So now he sends this patient to a lab and then the lab will do a culture. Okay. Now, after some washing, applying this and that, nothing is happening. This is another photograph. It came out, the patient is HIV positive. Okay. And this ulcer has been there. Now, this swab has brought this microbiology. Okay. The swab, which the doctor collected now, has brought this microbiology. I think it's not very clear. There are two organisms the swab has grown, Stenotrophomonas maltophilia, and the susceptibility you don't do, the lab has to know this. This is again training. You don't report all antibiotics, they have no activity on Stenotrophomonas maltophilia. It's a special pathogen. It is only septrin which has top class activity. Then if patient is sulfa allergic, you can choose minocycline or aquinolone. Okay. But if it is blood culture, we will give some other antibiotics. That's for another day. But this is not an invasive, it is from the swab, which is a surface culture. So the lab reported only 3 antibiotics. This lab, by the way, the pathologist, my student, knows excellent microbiology, was trained in Aga Khan University and has done the best job. Yeah. And there is also E. coli susceptible to 5 antibiotics, cefuroxime, ceftriaxone, augmentin, gentamicin, and ciprofloxacin. Okay. Now the doctor thought he should cover both these organisms. Okay. So he started this patient on levofloxacin and also cefuroxime. He has given her prescription for cefuroxime plus levofloxacin because he only knows to read this report and prescribe. How dangerous it is. Yeah, we are lamenting microbiology labs are not there, they are unable to do culture. But when they do culture, what is lacking? The clinician being able to understand the lab reports. There is another recent study which is published from US. I don't have that slide here. 70% of the clinicians do not understand the lab reports. This is in US. We are not talking about Kenya. If that was the case in US, what it would be in Kenya, we again leave it to imagination. Okay. So this doctor, that's all he understood. There is 2 organisms. There is this 3 antibiotics. There are those antibiotics. And I just have to prescribe both because I have to hit both these bugs. But here there is a comment. My student, Dr. E, has written. It says, organisms grown from wound swabs, especially enteric. This is E. coli. It's an enteric organism. Could be colonizers. Please correlate with the clinical background of this patient. What does it mean? You will only use these antibiotics if you know the history. The history is 5 to 6 months. These are colonizers. Colonizers means on this wound, there is exudate. It's a lot of rich food organisms which are environmental. E. coli is a fecal organism. It's like God, ubiquitous, present everywhere. E. coli is present everywhere. So E. coli colonizes and multiplies. And when you do a swab, you grow it on the bench. And the doctor in good faith has given the susceptibility and also given the comment, but the doctor did not read the comment. Okay. So how do you interpret culture reports? So the training, what international partners are doing is only lab, some pharmacy. After we clamored, clinicians have to be involved. Now they are involving clinicians. But how do you train clinicians in all the lab aspects, how to interpret chemistry, hematology, microbiology, all those things? How do you train them overnight? Who should be doing it? The medical schools and the universities. Okay. And that is where the problem is. KMTC, Kenya Poly, all our universities, Aga Khan, we have to do that job. It can't be international partners to teach the doctors. 5 years, they have already taken a degree. And now the international partner is doing training, 1 week training, 2 days training, nothing is happening. Okay. Billions of dollars are spent, but nothing is happening. So what was that ulcer? Chronic ulcer can be a common condition globally, chronic ulcers. Debility, pain, social distress, reduced quality of life. 3.6% of people older than 65 years can have a chronic ulcer. And these are all the reasons. Beyond this list, there are many reasons. Trauma, tumors, venous disease, arterial disease. Somebody mentioned here, could it be venous ulcer? Metabolic disorders, neuropathy, hematological disorders, infective diseases like anthrax, mycobacteria. If you have something like Mycobacterium ulcerans, Mycobacterium, other water environmental mycobacteria, they produce a chronic ulcer. Unless you hit the right bug, you need TB culture. And if you go on giving antibiotics, the patient's condition is worsening actually. Yeah. Then for management of ulcer, it's not just systemic antibiotics. There is something called local management. There are various modalities. The surgeons will tell you how you apply compressions, you clean the wound, you maintain this, you maintain that. Even there is a stem cell therapy for chronic wounds. And there is grafting. If it doesn't heal, they graft the skin. Okay, you can't leave it like that. It's very dangerous. So what is required? An interdisciplinary systematic assessment of the patient is required to plan specific treatment options. So the doctors should be taught, don't just do your own things, don't do swabs and treat with antibiotics. Refer this patient to a competent surgeon to a hospital. That's what should be done. So these are all the wise dictations which are available online. When you see a chronic ulcer, 1, 2, 3, 4, 5, all this is taught in the medical schools. There is also free online information. Thank you so much.
Another clap. I think maybe if you're for $1 million, you're asked, name one prof who can keep time. She has 10 minutes left. So we can ask her maybe like 5 questions. Maybe we start from the ground. Any question? Any question or comment? Question?
Thank you very much, Professor Revati. My question is on interpreting hospital antibiograms, because I think sometimes we assume that the catchment population is constant, and therefore what we get is representative of the population but we know that our care-seeking behavior actually makes it see quite a variety of people who are not constantly coming from the same place. So how do you make use of that information for the patients you're currently handling?
Thank you so much. That's a very good question. I think I covered that in the limitations. Hospital antibiogram is generated from a particular facility. That facility, the catchment population may not be constant. Yes, even if you say that, Moy Teaching Referral Hospital has some catchment area. People are coming from that area. Most of the time it may be true, maybe 70% it will be true, but you may have the 30% other population coming to that hospital. That is okay, but there is no standardization of how these cultures are coming to the lab. They are initiated by the clinician, the clinician's preference. Like a clinician in ICU, as he admits the patient, he does so many baseline cultures. There is another clinician who does not meeting. So unless you can control the practice and institute very strictly standard practice guidelines, and everybody is following it, like there's a patient coming to suspected meningitis, whoever is seeing him all over the hospital, 1, 2, 3, 4 will be done. Because it is practice of medicine. It's not dictation of medicine. Practice of law, practice of medicine is a discretion. Yeah? And if you do like that, that is a bundle approach. Automatically, any patient with upper respiratory will do this 1, 2, 3, 4, 5. It is a lot of waste of resources. We are realizing the bundles approach is a waste of resources. Don't have to do a bundle for everybody. It is now individualized medicine. You examine your patient, you pinpoint which investigations are going to be cost effective and which investigation you are going to act upon. If you do a blood culture, you have a plan that based on the blood culture result, I will do this. But if you order all those results are there in the file, nothing is happening. Nothing is changing. Most of the time, that is what is happening. So when you don't standardize those things, the data should be taken with a pinch of salt or with a fist of salt. I don't know. So to be very, very careful how you are applying the data. I gave you the example of the urine culture. The computer is bringing all of them as outpatient urine samples. But these patients were in the hospital last week, last month, couple of months ago. They were seen by in the ICU, HDU. They were in the dialysis unit. They pick all the hospital bloods, and when they bring urine, when they come for a review, all the doctors are asking for urine culture. These are not of resistance. Now, if you make your guideline based on that data, you are going to be getting more problems. Rather, you will promote antimicrobial resistance. You will not discourage, you will encourage. So currently what is happening all over the country is the quickly made AMR centers have texts releasing urine culture results. They don't know, call me count, they don't know which is uropathogen, which is not uropathogen, which is contaminant. It is happening even in big hospitals in the city. The texts independently report, they don't have the clinical background, their training is very limited. They should be moderated by a pathologist who's trained at that level. So when it doesn't happen, antibiotic susceptibilities are given. I've shown you the result in the case. There is E. coli, there is Staphylococcus maltopila, doctor prescribed two antibiotics. So what are you doing here? You are promoting AMR. So this is a case of microbiology lab promoting AMR big time. It's happening, actually. I don't know, I answered your question. Thank you.
Any question? Any other question from the floor? It's the only time you get to ask your question.
Why? They can ask any time.
Oh, okay.
You see, all those texts we mentor under Fleming Fund, they are on my phone actually.
Yes.
They ask me, they send pictures of the culture plates. What should we do? They send pictures of all contaminants. This is what, everybody has a machine now. It's dangerous. The machine you swab, you put the yellow organism, it's like lemon color. And the guy is sending me, it's a very big hospital lab. He's sending me that picture. This I have seen for the first time. What do we do? It's a contaminant, it's a dust organism, that's for blood culture. But if he doesn't ask me what he would do some sensitivities, release, and the doctor will prescribe microbiology. Because it's a micrococcus. Micrococcus is resistant to all antibiotics. So this is happening. The machines, automatic machines, especially private sector has bought all of them. There are no pathologists. It's very small number of hospitals have it.
We can go to another question from online. There's one asking, how comes our hospital can never grow a culture and the patient is really sick? I hear people laughing, so
That's a lovely, naive, lovely question. All the time our doctors are asking, so many people are asking. This is a lack of basic knowledge in the medical school. See, we failed. We have a whole 1 year of microbiology training, but that training remained by non-medical persons training. Those people who never go to the hospital ward, those are the trainers. So they don't add the clinical angle to the microbiology. Bacteriology is very specific when it comes to clinical bacteriology. There is what is called sensitivity and specificity of any lab test. And if you take culture, blood culture, the sensitivity doesn't go beyond 60%. For natural reasons, that is, God made it that way, that 40% of the blood cultures, the organisms do not grow. They are growing in the blood, but on the artificial culture plate, they fail to. It's nature. God made it that. So you have that gap of sensitivity specificity. Any lab test has what is called a level of pickup or detection limit. Below that limit, the test does not detect. Physically, it has that limitation, like why the load. A machine can detect up to 50 and above. If that machine you are using and the viral load is 40, it will not detect. But you use another machine which can detect up to 10, that is the detection limit has come down, it's more sensitive. You have increased the sensitivity 40 times and up to 10 viral particles per ml, the machine can detect. So a pathologist can interpret all these things. What is the detection limit? What is the sensitivity? What is the specificity? All these things can be interpreted. Otherwise, doctors very often they say, my patient is dying, your blood culture is negative. That is utter lack of basic knowledge. We failed. I, as a university, I failed.
We have another interesting question. What is the current, how are the current trends on vancomycin resistant enterococcus in our country?
Thank you so much. That is a question I can answer with the data. Okay, for a long time we said we never saw vancomycin resistance in enterococcus. Long ago we saw one patient, urine culture, vancomycin resistance. This was about 15 years ago. We sent it to Paris to characterize what kind of resistance. Is it plasmid mediated? If it is plasmid mediated, it will spread over. Luckily, it was not. And it was sort of, the lab in Pasteur Institute. They said this is of animal origin. The patient was lost, but maybe it was a contaminant. Recently, in the past 2 years, we have seen some blood cultures, Enterococcus specium, which is resistant to vancomycin. Unfortunately, COVID came at the same time. We did not do any sequencing studies, and also we can't ship organisms now the way we used to ship them. So we want to do it locally within our lab, sequence these isolates and check what kind of mechanisms they are. But the bad news, they are there. A small number, I think about 9 or 10 isolates in the freezer, all from patients admitted. Blood cultures, couple of urine cultures, and they are small. They don't give you a reason to start vancomycin empirical. And there is no vancomycin resistance so far we have seen in stuff. Okay. So far, no. Thank God.
This is another one. How come patients can go to India and come back with very serious bacterial infections?
They don't need to go to India for that. We have plenty here. Actually, if I tell you, the CRE, NDM was described in New Delhi first time. And the publication came out, I think, in 2008 and 9. But we had that isolate in the freezer in 2006 in Aga Khan. After NDM was published, because we wanted to sequence it, we wanted to do PCR, the same lab in Paris said we are unable to do this PCR, we don't know what mechanism, because they were not aware of NDM at the time. They didn't have the primers. Whatever primers were there, they didn't detect the enzyme. So they wrote to us, we are keeping the isolate, but we don't know what it is. But once NDM was published from the UK lab, Professor Walsh and his team, they got the primers from Professor Walsh, they ran the PCR and they said this is NDM. So what is means the NDM was already in Kenya before the publication which came out from India. Our isolate was much older, and these were patients seen in Aga Khan Hospital. They were between Matter, KNH, and then finally they came to Aga Khan, where now we have the diagnostics. We had a culture lab, so we cultured, found the organism, we stopped it, and we sent it to Paris, recognizing this as a new mechanism of this. So that paper we published in 2010, but the original NDM was published in 8 or 9. We published later when we borrowed primers from Professor Walsh's lab. So nobody needs to go to India. We have all those things.
That's very informative. I didn't even know that one. Maybe we can have a last question. My question is, how do you have similar data from level 5 county hospitals, since most of the data we're getting is from KNH and may not apply to other county hospitals?
Thank you. That is correct. That is exactly true. Lot of data, even on that One Health platform, which I showed you, lot of data, they downloaded from the Vitec machine in KNH. When we download from the KNH machine, what it means, we don't have the sample time. You know, the machine had lost it. There is no sample time. You don't know whether it is urine or blood or what. But when the data was too little from the counties, very small numbers, we took the KNH data. And right now we are trying to get all the data from the private hospitals. But I am advising that keep the private data separate because the resistance is likely to be very high. These are high-end patients. They have used a lot of antibiotics and they are, most of them are able to afford healthcare, so they live longer. A lot of patients in the private sector, 85, 96, the families bring them, put them in the ICU and tell, doctor, do everything, my mother has to be alive. You know, that kind of patients. They are living longer because of all these modern gadgets. And now they are Shamba cultivating all these buds. And we respect those families and they are there. And they are generating these buds. So the private data will show more resistance. So we have to separately analyze the data. Yes, we will collect the data from all the private labs because they are doing microbiology. But we should analyze it separately. That's a very good question. Thank you.
So another big clap for Daktari.
Clap for all the audience.
Thank you. So, unlike normal protocol, now is where we can introduce ourselves one by one, and then from which facility you come from, what's your profession, and maybe you can give a small. When Kenyans were given the mic, we are told small word on maybe what you're doing in your facility in terms of antimicrobial stewardship, right? So we'll start, we cannot say ladies first, okay, we'll start in a shape form, right? Just quickly, and then we go for our 30 minutes break, right?
Good morning, everyone. My name is Dr. Dilshad, pediatrician, infectious disease specialist at Aga Khan University Hospital, Nairobi. In terms of what I'm doing with antimicrobial stewardship, I'm part of the antimicrobial stewardship committee within Aga Khan, and also working with Prof. Roberts on the same. So I think most of the experiences I can confirm they're true, and yes, we have those. We accept the limitation, but we also acknowledge that help in how we are improving antimicrobial stewardship, both within the facility and the country. Thank you.
Good morning. My name is Dr. Moracha. I'm representing Nairobi UoN Hospital as the Chief Medical Officer. And what we are doing at Nairobi UoN Hospital is engaging. My role is spearheading the committees that also deal with the AMR. Thank you.
My name is Roberto Pilici. I come from Kenyatta National Hospital, a clinical pharmacist, and currently the pharmaceutical services. I've been a member of AMS since it started in KNH. It's sometimes way back in 2014, and I think I can describe myself as a champion. Thank you.
Good morning. My name is Elizabeth Muki. I'm a nursing officer working in KNH. Besides that, I'm also a wound care nurse, and I'm here representing our AG Director Nursing Services. But basically, what we are doing at our grassroots is that we have a wound care clinic whereby we are trying to sensitize nurses and also our medical team on wound swab and not more on pass swab, so that we can really get the real organism. Thank you.
Good morning, everyone. My name is Naomi Kariuki. I work at Kenyatta National Hospital, microbiology lab, as a lab technologist and in charge of microbiology lab. I'm also an AMS committee member, and as a lab, we do antibiotics for the hospital. Thank you.
Good morning, everyone. My name is Dr. William from Getting Students.
pharmacist here and also the secretary to research.
Good morning, everyone. My name is Janab Alwala, pediatrician and epidemiologist from the University of Nairobi Department of Pediatrics. From the clinical side of things, I work in the KNH-UoN unit, and we do have a multidisciplinary team there, which has been doing lots of work on IBC and AMS related to the multiple outbreaks we've had of MDR organisms. On the research side of things, we have directly participated in a surveillance which we just finished in 3 neonatal units in the country, looking at bloodstream infections, and indirectly we also have a clinical network of 24 pediatric facilities. And one of my colleagues have almost done doing a surveillance across 8 hospitals, some in Western Kenya and some in the central Nairobi region of bloodstream infections in all your children. So hopefully that will give better data on what is happening, at least in the pediatric population in this country. Thank you.
Good morning. My name is Rachel Oliech from Kenyatta National Hospital. I'm the IPC department. One of the roles we do surveillance on healthcare associated infections in relation to AMS.
Good morning. My name is Philomena Owende. I'm an obstetrician in gynecologist working at Kenyatta National Hospital, where I'm here as the Medicines and Therapeutics Committee Chair. AMS is a standing committee within the MTC, and we support a lot of AMS activities. Thank you.
Good morning, everyone. I am Webu, is my name. I'm a clinical pharmacist working at KNH. I am the secretary to the Medicine and Therapeutics Committee at KNH, and we support implementation of the AMS.
Good morning. Dorothy Iwat is my name. I'm a pharmacist at Kenyatta National Hospital. I'm interested in AMS and pharmacovigilance and patient safety in general. I'm the secretary of our AMS at KNH, and I don't have to support the activities that we have to, as AMS, that we come up with to be able to control AMR.
Morning, my name is Dr. Rao. I'm the head of pathology for Jalana Medical Services, which is in Westlands. We are a new facility, I think around 3 years old. And we are actually in the process of starting the antimicrobial stewardship program in our facility. We have a full-time ID specialist with us. So very soon our committee will be in place, and we will try to seek the guidance from Dr. Yuki how to take it forward. Thank you.
Morning, everyone. My name is Dr. Barbara Anita, clinical pharmacist by profession, currently the chief pharmacist at Dr. Resik Kataria Medical Services. We're actually working towards development of an AMS committee, where Dr. Lara said. We're actually also going to have a framework and develop the AMS guidelines also. So I'm looking forward to working with all of you. Thank you.
Morning, everyone. My name is Dr. Wangweka. I'm a pediatrician, pediatric ID specialist. I work at Kenyatta National Hospital Comprehensive Care Center. As regards AMS, I'm looking into research in ASP programs in the newborn unit.
Morning, everyone. My name is Dr. Phoebe Juma. I'm from Kenyatta National Hospital. I'm a physician. I work in the infectious diseases unit. With regard to AMR, I'm part of the infectious disease consult service. So all those patients with AMR infections who've been on multiple antibiotics, it's us who are called to consult. I'm also a member of the AMS committee, which was responsible for developing the current KNH guidelines. Thank you.
Good morning, everyone. My name is Adamaris Barongo. I'm the IPC coordinator and quality coordinator in Parklands Avenue, the main hospital. I'm 2 months old in the facility. Yes, we have the stewardship antimicrobial team, but not really active, and we're looking into activating this. I'm involved in collecting data, populating and analyzing the data in relation to hospital-acquired infections, the quality data, And I'm pleased from here we'll be able to activate our antimicrobial stewardship team and make it more active in relation to data-related practices. Thank you.
My name is Dr. Joe Bukia, provider of PSP from Graduate Hospital, infectious disease specialist.
Dr. Revati, Head of Clinical Microbiology in Aga Khan University Hospital now, but until 2006, early 2007, I was Head of Laboratory Medicine in KNH. I was working very closely with the Ministry of Health, which even now I do, but KNH I miss. I'm so happy to be here today. Thank you, Amaya, for this lovely opportunity. Like getting back to KNH.
So with that, my name is Dr. Amaya. I'm medical advisor to Sanofi and GE. So we'll adjourn this for a short break for around 25 minutes, and we'll be back. We'll be led by two presentations. The two major presenters. We'll hear from Dr. Mbudia, and we've had a lot of adult animals and something. Now we want to hear about children. Yes, so we'll hear about children in the next session, followed by Dr. Iwak, who will give us a picture of what we need to do in our facilities. As you can see, we have a very cultured, varied, inclusive attendance, both online. Online, we have a total of 1,400. Yes.
That is serious.
It's antimicrobial issues are serious, right? There's someone who has asked that there was an outbreak of a bacteria in a certain university. I won't mention which one. So many people are interested in finding out what to do, right? So we'll have our break, our short break, which is just next door. And please, regards to time, we'll be back here at exactly 10:45. You can brush shoulders, mingle with each other, and then we come back. Thank you.
So thank you very much. It gives me great pleasure to be here with you to share matters concerning antimicrobial resistance and antimicrobial stewardship, because that is the bedrock of addressing antimicrobial resistance, as you've already been told by the previous presenters. Now, these talks, you can relax. They'll be quite easy, as children are easy. So breathe in, breathe out, relax, they'll be easy. And most of the work I want to recognize that is being contributed to by my colleagues at the Gertrude Hospital, right? Dr. Winnie Akot, who is here, and Dr. Janet Maranga, our microbiologist at the lab, and various other people who have greatly assisted me in putting this together. For those of you who do not know, the only pediatric hospital in this region, and I doubt there is any, it's called Gertrude's Children's Hospital in Muthaiga. Gertrude's, who knows why the name Gertrude's? There's a good story, romantic love story behind it. And there was a man called Grogan. Who knows Grogan? Grogan Road, Gilogori. Yeah, rings a bell? This man donated the land for the hospital during one of the world wars for the people who went to war and left their families. So started as a care home for children of those who left for the war. But what about Grogan and Gertrude? Grogan, to win the love of his life, walked from the Cape to Cairo on foot. He walked to win her heart. So Gertrude was very dear to him, and in her honor, he gave the land for first the care place for children, a children's home, and then a hospital. And this is what it is now, looking good, but still child-friendly. It's a 103 bed capacity, sometimes you can see that, established in 1947. We have 19 satellite clinics and growing, and they are from all over the place, from the coast of Mombasa to the Kisumu, the land of lifestyles, and now here we're going to Meru. So it's got a very diverse catchment area with over 300,000 children attended to our outpatient clinics and 6,000 admissions at the main facility in Muthaiga per year. So as you will see, we have not just an urban population, we have semi-urban, peri-urban populations, and now we are heading into the rural areas. So it's a very diverse catchment. And we're looking that in the future we might have, when we do our data, very broad representation, probably national. So we've had a national antimicrobial stewardship program as old as the Kenyatta National Hospital from 2014, right? And ours is a multidisciplinary one with an infectious disease specialist as a chairperson, and then a chief pediatrician, chief pharmacist, pathologist. We have intensivists, ICU people, infection prevention and control team is a member of that. We have the outpatient doctor. As you can see, we have a big outpatient attendance. We have the pharmacist who serves as the secretary. We involve the nurse and even the training school, because we believe that people must learn about antimicrobial stewardship right at school. Now, we believe that antimicrobial stewardship strategies must be should be four-pronged, where we have guidelines at the top of things, standard guidelines, and then we have feedback and audits, staff education, and collaboration among various departments and players. So this is how our antimicrobial stewardship program revolves. And in terms of guidelines, we have standard treatment guidelines for common illnesses. I'll tell you a little bit more about it. We have a restricted antimicrobial policy. We have a surgical antimicrobial prophylaxis policy. Right, we have all those in place. We try to adhere to them, but there is room for improvement in terms of adherence. Prospective feedback of antimicrobial use. Now, we have regular audits, as I mentioned. This is where we look at data, how people are performing. And for instance, for our surgical cases, monthly we get reports on how the prophylaxis is going. For standard treatment guidelines at the outpatient mainly, this we do twice a month. And then point prevalence surveys, we do them annually. Restricted antimicrobial use, this is an ongoing 24 hours as audit. So when restricted antimicrobials are used, it immediately flags our attention and it triggers some action. So that's an ongoing exercise. Now, use of restricted antimicrobials. Our restricted antimicrobials are in the watch and reserve lists of the WHO program. So look it up. Now, our challenge with that, we're told it's 24 hours. It's quite intensive in terms of taking time, but it's doable. It takes a lot of commitment, especially from the pharmacy team. And then there is the challenge of people being guided on what they should use and not use. Usually that is quite tough. and also asking for them to seek help from an ID specialist. You saw from Professor Rebali's presentation where you should seek ID consultation from when you meet certain bugs or certain conditions. People don't always do that. And they're quite hesitant, sometimes with good reason. They claim they know. So we meet that and we meet opposition. But we have to be humble and see ways of working even with the toughest of people in order to protect our restricted antimicrobials. Staff education is key because you really need to get buy-in from everyone, right from the prescribers, the dispensers, and the dispensers and the administrators of the drug, the nursing staff, right? So everyone must be on board because there should be a check at every point if you are to get a good stewardship program going. So get them on board by educating them continually on the program, and when new things come up, just keep engaging them so that they can accept and implement your recommendation. For instance, the one of say, okay, like you saw in cases of sepsis and life-threatening infection, from Professor Rebali's talk that antimicrobials must be started immediately without delay, within 30 minutes, especially in septic shock. Right? Within 30 minutes, that antibiotic must be in the blood system. So what do you do after that? 24, 48 hours, when you have your data from the lab, you can then de-escalate and modify your treatment based on the ongoing development with your patient. So the education needs to be implemented through various continuous professional development forums. We do that both for the general hospital and then with groups. We go to pediatricians in their group. We go to the nursing staff in their groups, pharmacists when they have their forum. We engage with all of those. We have also developed an AMS training module. We intend to give it for those who are pre-service in training, but also to onboard new staff, particularly the prescribers, right? When new staff are engaged, we'd like them to go through this before they can say that they have gone through their induction period. And we'd like to make it mandatory with the hospital support. And we wish this could be something that can be done for every person who is graduating and getting into clinical practice. And as I said, we have standard treatment guidelines, which we updated in 2 years. And we actually require that the newly onboarded doctors, newly recruited doctors, go through that standard treatment guideline during their induction. This would be not just the medical officer, but also the pediatricians. Sadly, this doesn't go to the surgeon because they're coming at a specialist level, but we do really need to engage them so that they are aware that we have certain policies and we have a certain program going on that may require them to behave in a certain way. Labor intensive, sometimes also emotional, and we really do need buy-in from everyone and cooperation. What about collaboration? As you heard from the previous speaker, it is an expensive exercise to get staff to donate time for stewardship services. It is expensive because the employer needs an output, and sometimes AMS doesn't have an actual output that you can tell your employer, this is what I earned today. So you need support. You need also to be supported to continue learning share the knowledge and experience. We also need resources, especially when you're developing materials for patient education. So we've partnered over time with others, like the ones you can see there, especially when we were carrying out our first point prevalence survey. We didn't have the skills and we needed someone to walk us through. We are at the moment having an accreditation for antimicrobial stewardship program, an international accreditation, and in that we are also being supported with the funding from a pharmaceutical. So partnership is important, even for not just for institutions, but also for nations, right? So to implement AMS, you need partners. Right. I mentioned about public engagement, and we usually do this. I don't know who is, I'm sure all of you know that in December, rather November or February, we have an antimicrobial awareness week, right? We are quite strong on this. During this week, we have various activities that engage the public and the people who come to the institution, and we usually make them aware that antimicrobials need to be used judiciously. So we have those campaigns at the institution, but also we engage the public by doing press releases, yeah, interviews, and all of that, so that we can make everyone aware that it's dangerous to use antimicrobials irresponsibly, especially when they are not required. And in judicious use, you can promote resistance, which is a dangerous thing. So we have challenges. We are not yet there. We are striving to get to excellence, but we are not yet there. And our wish list is establishing a multidisciplinary AMS world round, particularly to see patients who might be having MDR infections or infections with difficult to treat bugs. I'm happy that Kenyatta usually at least sends a specialist, but it would be useful if such a review of difficult patients is done in a multidisciplinary manner, where you have IPC person, you have the lab, you have the pharmacy, and especially for interpretation of lab results, you will need the lab, you will need the IPC to prevent that bug from spreading. You need the nurse so that they know how to also implement the IPC. So it's best if it's a multidisciplinary approach and involving the primary doctor in that team, so that you can address the problem and, if possible, look at its root cause also. We also would wish to educate the prescribers and the practitioners on intravenous to oral switch, because it saves a lot on cost and time, and it's effective. In pediatrics, probably tricky, because kids sometimes, if they're having a serious infection, they may still be vomiting or having diarrhea, and it may not be, or they may be very poor at taking oral drugs, and you want that infection cleared. So it's there, we want to do it, but we want to do it in context of pediatric practice. Then there is, right, selective reporting of antimicrobial results, right? Antimicrobial, lab stewardship, It was alluded to by the previous speaker, Professor Rebati, so well, that the person requesting for the lab test or for a culture may not get everything, especially because they may not be having the capacity to interpret that result very well. you've seen the risk of giving people some antimicrobial resistance patterns in her last case. So that sometimes can lead to more harm than good. So if there is a policy worked out between the AMS team in collaboration with the lab to do selective reporting, that can go a long way in protecting resistance. Right? Then there is the improved utilization of the antibiograms. It's very nice to have it, to develop it from the lab and have it available. But is it being used? Is it being referred to when guidelines are being made, local guidelines, right? Or are we looking at the CDC resistance patterns from the US or from India or from the New Zealand? No, let's look at our local data because we have our own unique patterns, behaviors and patterns. So the more antibiograms we have, and especially good ones, the better. And let us utilize them to make local treatment guidelines. That's as far as my introductory presentation is concerned. Any comments so far? Concerns? I'd like to hear from you.
Any questions?
Or interaction. Let's not just be one way. Let's go two way. Okay. Data. Now I want to take you through our antibiogram for the Gertrude Hospital with all its satellites. Okay, that's why it was important for me to show you the catchment area to give you the introductory part before I give you the AMR data. Now, this, because of the number of isolates, we had to do data or collect data from 2016 to 2020, 5-year on blood cultures, and I'll tell you why. For urine and other cultures, 2019 to 2020, that's a 3-year period, right? And we classified the data into specimen types, and then inpatient versus outpatient, and data that was incomplete was excluded from analysis. I'm just simplifying how we got there. And our isolates, let's go past to urine cultures for the outpatient department. We were able to analyze around 500 isolates, right? Most of them were E. coli, with a few being Kleb pneumo, Proteus, and others. Now, Prof. Rebadi mentioned the trickiness of looking at outpatient urines in adults because of those people with chronic renal conditions who have complicated histories also coming in as outpatients, right? For kids, you have other challenges in urine, especially with the younger ones, whom you cannot give a container and tell them, go to the loo, pee a little bit fast, stop, then give me the midstream, and then throw in feed the rest in the pan or in the loo. Very complicated. Usually they pee when they want to, or when the bladder is full, unawares. And how do we collect the urine? We stick a bag, if we can, a collector. I don't know if that's available in the public sector. Is it? Urine collectors? Those from Kenyatta? Daktari? You see? So getting urines, it's hard from children. At least we try. At least we try. So getting a urine sample with a urine collector means invariably it will be in contact with the skin, perineal skin, right? And therefore, the rate of contamination of that urine may be high, right? Kids usually pee and poo at the same time. True, we all do. But then the urine collector may at the same time collect a little bit of this. And sometimes, so as we look at these urine reports, you have to have that information in mind as you interpret them. Okay, so those are the numbers, and therefore these are pretty good to make an antibiograph from, because there are a good number of isolates, especially for the E. coli, but for the other organisms, the interpretation will be different because the data may not be very strong because of the numbers. You may not be able to read everything, but of the more than or nearly 400 isolates that you analyze for E. coli in the outpatients, right? The drugs that are commonly used in the outpatient settings, cefuroxime is one. I don't know if you can see that. At 91% sensitivity, 91% of the isolates were sensitive to cefuroxime. Amoxicillin clavulanic acid as well at 91. If they required to go to inpatient, amikacin was at 98. 98. Right? So you can see we have options. We have options. Cotrimoxazole is useless, of course, and so is ampicillin. So most of the other drugs are effective. So E. coli urines in the outpatient setting would be not a very difficult job to do, to eliminate or to treat. What about if you isolate proteins? Again, the isolates were over 20, so we can analyze the data, but you can see it's only 32, so the data is not extremely strong, but at least we can see there are no big challenges except for nitrofurantoin and ampicillin. So if you're dealing with protease UTI, those are two drugs you will want to avoid for children you are treating at the Gertrude's Hospital. Klebsiella, again, we had over 20 isolates, so again, 25 isolates, not very strong evidence, but it tells you nitrofurantoin and ampicillin and a few other drugs like pitard, strangely, cotrimoxazole, ceftriaxone, those may not be quite effective. So for cleft pneumonia, you may want to consult. If you see cleft pneumonia in urine, you may need to consult an ID or your microbiology lab to see how best to do it and to follow up. Okay. Now, the others that we saw, are inpatient isolates. Here you can see the E. coli were not that many, well, a little less than we had in the outpatient setting where over 80% were E. coli. Here it's about 60% of E. coli, and then we have a bigger representation of the others, especially the one that we saw last week. It's a bit difficult to explain more, right? You want to see Enterococci faecium. Remember what I said about the difficulties of collecting urines in kids? So that's one of them. Right, then let's see a bit more about the details. The E. coli in the inpatient setting looks like a little bit different from what we saw at the outpatient setting. Your ceftriaxone, which was at 91% isolates sensitive, here it's scoring at 69 isolates sensitive, right? Amoxicillin clavulanic again was at 91. Here we see at 69%, but probably not be very worried when you see that the isolates are only 16. So the data is not very strong, but at least it indicates that those who are in the inpatient setting may have a different resistance pattern for E. coli UTIs. Probably those ones that you are admitting are the ones with posterior urethral valves, hydronephrosis, right? Hydroureters, reflux, right? So those may be the ones. The other isolates of the Klebsiella in the inpatient setting, the isolates were too few to give you the sensitivities, right? So we'll leave the urines and now go to swabs. In the swabs, we had 203 isolates. Unfortunately, we won't tell you from what they were they past swabs, were they from wounds, contaminated wounds, surgical site wounds, or at abscesses that were being drained. Unfortunately, or were they from swabs or from eye swabs? They were just lumped together as swabs. In future antibiograms, we might be able to differentiate the sample types, but at least we had 203 isolates that we could talk about. Happily, we want to say that oxacillin sensitivity for our Staph aureus was at 97, very decent, very, very decent. So those of you who are treating abscesses and things, if you see them putting people on broad spectrum antibiotics for children, tell them it's not necessary in our setting. It's not necessary. We've got very good sensitivity, right? Those are inpatient swabs, and even in the outpatient swabs, 93% oxacillin sensitivity, right? So we need not go to the vancomycins, and I don't know who else for our Staph aureus in children. Blood cultures, and I told you we looked at positive blood cultures over a 5-year period because of the small numbers, right? I want us here to note that of 101 isolates that we could analyze in those 5 years, a majority of them were coagulase negative Staph aureus. All right, they are abbreviated as CONS because they con you. They con you into treating them but they really shouldn't. You shouldn't be treating them. So these cones, how do we get them? Yeah? From contamination with the skin when we are taking the blood samples. So now back to how do we collect blood samples from kids? Aluvala. Your 1 kilogram guys, how do you get your 5 ml from that? Yeah, I've seen all kinds of things, milking, dripping. Yeah, kweli wrong. Yeah. Sometimes you collect in one site 1 ml, it dries up, you go to another site. You may not have the time to sterilize and prepare the skin very well. So blood cultures, especially in the smaller age groups and neonates and preterms, unless you've had a good, a well-collected sample, they're very tricky to interpret, right? They're very tricky to interpret. Then you are told about the sensitivity. Only about 60% of blood cultures will grow when taken to lab. Some of the reasons is prior treatment. When somebody has had an antibiotic, even if it's oral, this would be an inhibitor when that blood is put on a culture media. That antibiotic in the blood will be an inhibitor, so you not get a growth. You not get a growth. So even if a person is on an antibiotic that is not effective or killing that organism, it may still be an inhibitor at the time you go to do the culture. So yes, the patient is very sick, looking very septic, but when you do the blood cultures, no growth because of the inhibitor of growth in the lab. That said, right, for our staph aureus, we only had 7 isolates, E. coli 5, Enterococci 3, Clade pneumo 3, Streptococci 5, and environmental contaminants 7. Staph aureus, the 7 isolates, because we don't tell you about the cones. We don't want to con you. Our staph aureus, look again at the oxacillin. The numbers are small, but we still have a good oxacillin sensitivity, right? So again, when you're suspecting staph infections, you need not go to broad spectrum in pigs or looking for oxacillin resistant bugs in pigs. And this is something we keep engaging, especially in our ICUs, right? That, hang on, do we have evidence that the basic antibiotic, the narrow spectrum oxacillin will not work? Why do you need to put them on vancomycin? As a first line, because you thought they were pretty sick. You don't. You need to get the evidence. Use evidence in your treatment. That way you will not invite AMR, right? So although the numbers are small, they are still reassuring. E. coli is tricky if you isolate it in blood, and especially make sure, if it's E. coli, make sure you get a good sample. If it was picked from the groin, from the femoral vein, be careful, right? So that one, the 5 isolates we had very difficult sensitivities. And if you are sure that you've got a good blood sample, then that way, with good interpretation, meropenem or carbapenem may be used. That way you are enabled to use a reserve antibiotic. So think we stop sharing. So that's our antibiogram. The main message is that we still do not have a major antimicrobial resistance in pediatric settings at Gertrude's Hospital. I want to put a caveat, and that's why I give you the setting. We do not have a big neonatal number. Yes, we have a NICU. We get referrals. We do not have any association with any maternity, so we do not have a neonatal unit. We get a few referrals of neonates, but we have a small number. So our numbers are exclusive of NICU, right? Yeah. So thank you. Concerns, questions, clarifications on that antibiogram? Or would you like to hold on until we come to the final discussions? Right? Now, this one I want us to be all alert and interactive because it's a case presentation. It's somebody you also, right? Don't you know him? Mr. XY? He's 1 year old who weighed 9.3 kilograms, right? This boy was admitted for neurological assessment and management of gastroesophageal reflux disease. Right? Do you know such a kid? Those of you who work in pediatrics, they are familiar. They are familiar because they are forever in our clinics, especially if they have gastroesophageal reflux. Yeah? What does it trigger in your mind? Gastroesophageal reflux. Aspirations, recurrent aspiration pneumonias, right? What about neurological assessment? So this is probably a fellow with developmental delay, right? What does that lead you to think about? What would you like to know from the history? Yeah, anyone, you won't be wrong. Huh? Did I hear that? The name of the man? Sorry, I will disclose. Sorry? Delayed. Birth weight, birth history, yes, very important. Right. He cannot sit at 1 year, just starting to hold his neck, and he doesn't respond when called. Cries a lot at night, meaning he's probably got some irritability, some encephalitis of some sort, or some discomfort, some pain. He was delivered by CS because he was transverse lie. The mom was put under GA and was told that the child cried at birth, but was blue and required oxygenation. And they stayed in hospital for 1 full week. Right? So, what do we have here? What's the end result of this bad history? Say, maybe you want to take the
cerebral palsy.
Cerebral palsy, good. From as a result of bad asphyxia, I hear, yes, which results in
Looking upon the history and everything, could be hypoxic ischemic encephalopathy.
Precisely. Great. Yes. So this is a child who, from that story, got some hypoxic ischemic encephalopathy. So history is important. Now he's in hospital. That's why he's come. So he came in as an elective case. All right. He wasn't ill when he came. Came in as an elective case to manage the gastroesophageal reflux and for neurological assessment. Now, the following morning, he started vomiting, he had loose stools, and his temperature shot 38.7 in the morning. This is what the pediatrician ordered. What more would you have requested for? On our little boy, Mr. XY, this is what was ordered. What would you include to enable you to assess them? Take them. Let's discuss. It's not one way, and it won't be wrong.
Most importantly, I'm not seeing the full hemogram.
Good. Yes. What would you like to see in the full hemogram?
Full hemogram, first we would like to see the total leukocyte count.
Yes.
And that is the WBC count, and of course the differentials, whether it's a lymphocytosis or, and what's the absolute neutrophil count.
Yes. And this is important, diagnostic stewardship, because that will give you a lot of information, right? We ask sometimes for tests and then we don't utilize them. They have a cost to the patient, especially. I mean, they have a cost to someone, even when they are being paid for. So request for tests that will help you with the management of the case. So what else would you like to ask for? In addition to this, so we have a hemogram in addition to this.
CRP.
Yep, inflammatory markers. And sometimes I see people ask for several inflammatory markers. Interleukin 6, procalcitonin, right? ESR, all of them. Forward. Right? It's like hitting ugali with uji. Yeah. Correct? So, what else? Come on, let's go. Anything else you'd like to do in terms of diagnostics?
I'm thinking a blood culture would be relevant.
Sorry?
A blood culture.
A blood culture, yes. Thank you. Yes, it would be important. Remember, this child is not on antimicrobials, and this is your opportunity if you have a bacterial infection to pick it up. Great. Let's now proceed.
May I ask?
Yes.
Wondering, microscopic
Exactly. Yes, you would want to do, if you can, some viral infections. This is the age of viral gastroenteritis. It's good to hear this from an obstetrician. You have an interest in your own, in the product of your work. Thank you. Yes, that is important.
Maybe we would also like to include stool H. pylori.
Yeah, reluctantly, because at 1 year, it may be tricky to interpret that. Kids have H. pylori, which will not give them any problems at all. So if it's there, it may not be very useful. Yeah. But yes, for an older person, it may be something you ask. Let's now see what was done. I'll give you some results so we can move on. So that's your hemogram, full blood count. Is it legible from where you are? Good. White cell count 11.65. Yeah. Lymphocyte count which you wanted to have 8.0 absolute. And percentage, where is it? Of 17.3 neutrophils. Neutrophil percentage 17.3. What does that tell you? Are we dealing with, what sort of organism are we likely to be dealing with? Viral. Reason? Lymphocytosis in a 1-year-old. So that's why our stool virology would be important. The urine that you have is there. Look at it. Right? Look at it carefully. And that is the culture report, which came at 48 hours. Good. You see, you're given the growth, gram-negative bacilli, Klebsiella pneumonia, and here are your susceptibilities. Right? Only susceptible to amikacin and meropenem. For sure, remember what I showed you in the antibiogram. Thiazine. So how would you treat this fellow? Come on, let's go on. He has a fever, you've grown something. I've given you the sensitivities, please. Help me to treat him. What's so difficult? It's only a choice of two things. Which of the two would you choose? Say.
We were just discussing and we were saying, we said there is no bacterial infection. So why are we giving the antibiotic?
A+ for that. Let's give him a clap. Let's applaud him because that is the flow and that's the learning point, right? You look at that urine, is there infection? Is there a UTI? The parcels, nil, right? Nitrites, nil, right? Proteins, nil. And then you're given a culture, a growth. Again, if you look at this report in detail, what's the colony count? 10 to the 3. Is that significant? Not really. You want to notice growth that are 10 to the 5 to the power 5 and more. So this is an insignificant growth in a urine of someone that is not contaminated, who doesn't have a UTI, and recalling how the urine was collected, probably a contaminant. But what did the good clinicians do? This fellow was put on meropenem. Yes, he was. And this was fiercely defended because there was lab evidence of an MDR. Yeah. It was fiercely defended. The boy was febrile, there was a growth, an NDR growth. So why use telling me I shouldn't use meropenem? So this is a battle for them. This is part of what we do at the AMS team at the hospital. And that should be part of your work as AMS teams, right? To implement diagnostic stewardship alongside antimicrobial stewardship and good relations, collaboration with the clinicians, make them understand why you are reaching that conclusion, have the lab assist them to interpret the results of the lab test that they have asked for, and therefore use those results for the benefit of the patient at the least possible cost. That was my message. Right? So once again, and to reiterate, I want to say that interpretation of microbiology results in relation to the clinical picture is crucial. It's crucial. And collaboration between the clinical teams and the pathology teams in the guidelines also of the pharmacy teams. Yeah, your clinical pharmacologist. Let's all work together. And that's why I say this combined AMS world round is very, very important, especially for difficult to treat patients. The other message I want to leave you with is that when you see an MDR, look again at the information, at the data. Is it really the one causing the disease? Can you confirm that culture? Right? If it was a blood culture, is it present in more than one sample? Right? So if the result you are getting, what's the veracity of that report? Right? Verify if you can, confirm before you go for the heavy guns, which are also expensive, have to be given IV, therefore you keep your patient in the hospital for a long time. It's good to be reasonably certain that MDR is present. Good, thank you. That was my message. Now we can talk.
I'd like to say thank you so much. Hearty clap again. But I think we have quite the engagement. There are various questions, but we shall start from the floor part. Is there any question? Okay.
For me, it's a concern. I was a bit concerned. Why did the doctor choose to do a urine test? A urine culture for this patient who didn't have any urinary symptoms? Just
in pediatrics, we like to do urine when we are investigating fever, especially new fever. Children, as you know, may not tell you suprapubic pain or I'm having to go to the loo too much. So it's part of the routine investigation of fever in children. Yes.
Thank you. The other question is regarding the presentation that you went prior to this, and going by the health seeking behavior of our patients. They prefer going first to a dispensing pharmacy, for treatment, and it's rather obvious even for food, they will get an antibiotic. So what can we do differently? Because by the time we encounter this patient already in the hospital, they have already received maybe the second dose of antibiotics.
Good, and I think that's why we are here. I do not have the answers, and I'd like the audience to help me. What can we do different?
Maybe we can have the pharmacy team.
And everyone.
I remember when I think when mother knows mentioned like that, I'm okay. We used to eat these things with breakfast and lunch.
Thank you. Just to indicate that I have conflict of interest. I was a board member at Pharmacy and Poisons Board for 3 years. And one of the things we tried to do was in terms of enforcing the rules and the regulations. The law is clear. Antibiotics are prescription only medicines. They are part 1 poisons. So they are restricted in Rule 2, access only through prescription. But we had a comment from Dr. Royce in the morning, the difference when she was abroad somewhere and when she is in Kenya. So for us really is behavior change. In our retail pharmacy sector, there's been a lot of infiltration. We speak about quads everywhere. So for us, and I know the current chair of the board was given some directive by the president. One of them was to root out quads. I will pray for him to succeed. Thank you.
You touched on an important thing, regulation and registration. Looking around, who has gray eyebrows like me here? Yeah, good. So I can tell you a story. I trained in KNH, as all of us did at that time. Adil, your beard is gray, but not your eyebrows. So you're aspiring. So this is implementable. In the days I trained, there were people called drug inspectors, right? And there were drug registers at every dispensing point. Drug inspectors would come and check your drug register, those part 1 poisons, balance your prescriptions with your stocks. You don't, you're in trouble. Right? It was done. Then, I don't know when the rain started beating us, but it can still be done with enough will and commitment. Go just a little bit south to South Africa. Yeah? You cannot buy things even in a pharmacy without a prescription. Those part 1 poison in South Africa. Don't even go abroad, happen to, because you haven't gone overseas. Yeah? So it can be done. Legislation and enforcement. Thank you. Let's address another concern.
Thank you so much for the presentations. So my questions are around the ASV program in Gertrude's, and you talked about the guidelines and the challenge adherence to the guidelines. So do you have like the adherence in percentages to the guidelines and also to the prospective feedback and audit? What are the acceptance rates? And how can you guide someone who wants to start a similar program in terms of getting that acceptance and adherence to guidelines and to the audit feedback?
Great. Please give the mic to Dr. Winnie Akol. Yes, we have I'll let her answer that, then I'll add if I can.
With the audit, we, for example, the surgery antimicrobial prophylaxis audit, we usually analyze the data on a monthly basis and discuss it at our meeting, and we give feedback to the surgeons. We usually have regular meetings with their own cadre and tell them, you guys are prescribing prophylactic antibiotics where they don't need to be given, or you're giving post-surgical antibiotics after. So the feedback is usually good because then the respective person is aware of the impact of their choices. For our common conditions in our outpatient department, we of course have the standard treatment guidelines. So we do a bi-monthly audit where we sample prescriptions from every prescriber irrespective of impact for particular conditions. So for enforcement there, we actually integrated the scores into their performance appraisal. So it reflects in your performance when you're being appraised. So it has helped us with enforcing that, but also we do have regular sessions where we continue to preach the gospel. This is like, when do we do second line and that, but of course with the implementation has come a bit of resistance, as Dr. Mudia has mentioned. There's someone who's like, why does this ID specialist, why is he the person to tell me what to choose? I did that by an infectious disease, you get such comments. But with consistency, you get to see an improvement. Our biggest limitation is most of the audits, I get to do them myself. Sometimes you find that when I'm on leave, a performance tasks again, then it's a reminder. So that's where maybe we are working on and just strengthening what we put in.
Thank you.
Clarification. So basically, when you're doing the audit is for the T-sheets only, the prescribed drug antibiotics. Or is there any other inclusive audit metrics that you do?
So for most of our audit staff that have given us an upper hand is we have an electronic hospital system. So it's easier to get the prescriptions if we want to sample them. But for like our theater, most of the prophylactic antibiotics are prescribed in theater in the files, in the patient file. They're not put in the electronic system. So we just someone there to be keeping a record of which patient is given at what dose. And then now we analyze, now with respect to our policy, what needs to have prophylactic antibiotics, what does it need to have? Yes, yes.
Thank you, Winnie, for making it clear for them. The audits require, as I said, commitment. And the institution needs also to make available the person doing the audit. Feedback improves performance overall, and especially the adherence to standard treatment guidelines. When the surgeons saw how poorly they were scoring, because when we started the program for them, prophylactic antimicrobial prescriptions, everyone kind of 100% used to have. Some who required prophylaxis got the wrong prophylaxis. So we got them to write the guidelines with us. And therefore, when they saw that they are adhering at 10% to the guidelines that they wrote, they condemned themselves, and therefore the behavior change comes in. So behavior change comes in with information, consistency, and involving everyone. Let them move along with you. Okay. So even for generally in this country, for antimicrobial stewardship, we need to bring the users of antibiotics along, right? Let's educate them. Let's make them know when to and how to use antimicrobials, right?
So I think we can have a question from the online team who are very interested in asking you questions. Thanks for the very informative presentation. I would like to know, was Gator's AMR data from the main hospital or did it include satellite clinics, especially ones based out of Nairobi? Given the paucity of diagnosis in public sector, would you advise on the extrapolation and utility of the same in this setup?
Our antibiogram involved, especially, I showed you like the urine samples from the outpatient and also the pus swabs. Some of them are from outpatient. All our data is integrated, right? All our data, be it from Mombasa, from Kisumu, from Kitengela, Syokimau, we integrate all our data from the satellites. But however, all the inpatient data is from Muthaiga. So we miss out on the inpatients from Mombasa because we refer them to other facilities and from Kisumu, right? So that is the difference. As to their, can we use them, extrapolate them to the public sector? Maybe, if maybe we have a selected population, but probably not that selected, because at times when we have NHIF program, we see people from very humble background, right? People with insurances, from humble background, right? So let's say like we have a broad catchment. So in a way, where we have strong data with a good number of isolates, I would say perhaps they can be extrapolated. Where we have small numbers, maybe we can join up or add up those numbers with those from the bigger facilities and come up with a more meaningful antibiogram. That said, our private institutions, like, let's say, like the Nairobi Hospital, where I'm on the AMS team, if you are allowed to separate the urine samples, the children's urine samples, that's a big headache for them, because from their lab data, the computerization hasn't reached that level that they can pick, let's say, the under 14s, the urines from the under 14s in their system. So it's near impossible to get pediatric isolates at certain institutions. I don't even know about Aga Khan. Can you get them stratified according to it? Maybe, yeah, probably. So we're getting there, but we're looking to where we can collaborate and have more meaningful data by using data from other private institutions or all the institutions that can get on board and probably have a national antibiogram for different conditions, different age groups. Yeah. Thank you. That was a good question.
There's another question. When choosing antibiotics according to the sensitivity in the antibiogram, do we start with a drug with the highest percentage as the first line?
Maybe, but I look at what has a narrow spectrum and good sensitivity, not necessarily the highest, but effective. If you are keen, you could go to the microbiology lab and ask for the specific MICs. Or if you're not up to that level yet, you ask the microbiologist, given this list, what would you advise me to pick out of this list? And they'll give you their best choice. Okay. and you will want to talk to the pharmacist and see what is the narrowest spectrum, best effectiveness, and a good profile for side effects, toxicity profile, right? For children, you also want to see what is easy to also administer and acceptable to the child, especially if it's oral, right? So there are those factors when it comes to the choice.
Have a last question before we go to our next speaker. Is using start doses of antibiotics effective?
What would you be treating with a start dose?
Bacteria.
It depends.
I'll make this because also in the clinical practice, a lot of clinicians like start doses.
Is it a start dose or a loading dose?
A start dose. Okay, call it start dose.
No, that's not recommended practice. Not in all these, no situations, yeah.
Just a comment on start dosing.
Mm.
I mean, from my understanding, it was given once and then to stop. So that can be applicable in surgical prophylaxis, like what you do for clean cesarean sections, where you give it within 30 minutes of the skin incision. When every video incision is not contaminated and you don't have to continue antibiotics. So a single start dose is effective.
Yeah, good. Thank you very much for assisting me. But what about gonorrhea? Now that you're talking to, what about some STIs?
Yes, so for our guidelines for sexually transmitted infection, say for gonorrhea, chlamydia, and pelvic inflammatory disease that is likely caused by gonorrhea and chlamydia, then we go combination, but with the gonorrhea and chlamydia in mind. So yes, you will give a third generation start dose for gonorrhea, so that's still within our guidelines. And then you can give a macrolide or a macrolide or a doxycycline to cover for chlamydia, and then the anaerobe, so that will be metronidazole. Yeah. So for GC, it will be a start dose for third generation kefals for you.
Great. So that for that question, loading doses, look at your standard treatment guidelines. Start doses in certain conditions, and in pediatrics we have STIs as well. So know those that you can treat with one dose and those that require a course of treatment. So thank you very much. You've been a good audience and interactive. I really appreciate it.
Thank you, Dr. Ray. We would like you to invite the next speaker.
Hello.
Dr. Iwa Dorothy. As she's coming also, we have a small Dr. Maribel Martin. She'll make a small session.
Shall we start and stand and welcome Dr. Hello. Karibu, Dr. Hello. Funga. Fungua. You may see. Hello.
Hello, Dr. Maribel, you're online.
Hello, can you guys hear me? Let's just go ahead. Can you guys hear me? Dr. Maritim, please go ahead. We can hear you. Yes, kindly go ahead.
So as we set that up for Dr. Marybeth, as we sort out the sound, we're hoping that when we just take a break, your sound will be back and you can ask your question or add your comment.
Hello, can you?
At the end of the session. So thank you for that warm welcome. It's a bit intimidating to come and speak after 3 great speakers because now the bar is set so high. So I will ask for grace in advance. So my disclosure is my bar is not as high as theirs. So if they are gymnasts, me, I'm the ones who are just still on the playing mat. So I'm hoping that by the end of this, we'll be thinking of how practically we can implement or scale up our AMS interventions within our facility. So when I share the hospital case example, I'm going to look at it in terms of a system. It's a system issue and not at a patient level. I think we've done earlier the first 3 presenters focused on the patient, but now I want to look at the system. Because I like to think of myself as a system thinker, and that's the way we'll go. So our case example, I was hoping it's not me who IT challenges will find here. But so I want to hope from the other side that the online audience can actually see the slides. They can. Okay, so I'll just proceed. So I'll just give a background of where the case is coming from. This is borrowing from what happened in what we went through in KNH some few months back when we had the cases of the Klebsiella, the MDR Klebsiella, and the children that we lost at that time, and just looking at what it is that, how it is in terms of AMS IPC response that was triggered to be able to address the situation. And I'm hoping that through this presentation, I'm thinking of 2 things. For the sake of KNH and other institutions which have gone through the same, to think of it as being now a never event, that we don't have such a situation taking place. And for those who have not gone through, don't wait to go through it. Learn from that and then make it an event that does not now take place in your institution. So we use that as a chance to learn what it is was best practice or the response. Here, I'm hoping that will drive a more proactive response to AMS, that's antimicrobial stewardship, to be more proactive about how we handle the issue as opposed to reactive. So like now I'll give an example of KRA. I don't know how many are actually waiting for the 30th of June to file their returns.
So we want to think in terms of handling AMR the same way, not waiting until it hits you, or not waiting until a situation gets to you for you to address it. So KNH has a newborn unit, which is a 60-bed capacity. It has 6 beds NICU, that's the newborn ICU, and a 6-bed HDU. It also has a 5-bed isolation unit and is able to ventilate 1 neonate. However, average occupancy, we don't have the benefit of soft life of Gertrude's, is 140%, meaning that definitely we have more children in those beds than the capacity. With the 6 admissions daily, Dr. Lubala can be able to, he sees this as his day-to-day, with an average length of stay of 14.3 days, and the challenges of staffing. I think for ICU, the nurses who are in the room and those who are following, say for an ICU setting, you want 1-to-1, but we're working in a scenario of 1-to-3. And in other nurseries, you have 1-to-6 to 10. One nurse nursing 6 or up to 10 children. So in our situation, when we are looking at the AMS concern, the concern here was the increased mortality that was noted in that period in August. And the neonates were noted to have positive cultures for multi-drug resistant Kleb pneumonia. And laboratory confirmation of the same was done. So what was done to address the concern? There was an outbreak management team that was set up a month later that is multidisciplinary. And earlier when Dr. Lubala was introducing himself, he mentioned that the team at newborn unit is multidisciplinary. And a lot of what happens within KNH is done in multidisciplinary teams. And those participation of the quality health department, the senior management support. I think most of you are familiar with this because it's interesting. Bad news really sells. People don't come, and even when we reattach a hand, they don't talk about it for like lunchtime news and evening news. They just, it's a small, those lines that follow with stock exchange at the bottom of the screen. But when something goes wrong, it is always replicated as though that is a standard practice. But we'll use those situations to learn from them so that we can improve. So there are meetings which were routinely held with specific action points and support from the MAP AMR project on the same. So, and to acknowledge the IPC team and the multidisciplinary team for being able to identify several gaps. And I know Rachel, who's with us, is going to be able to give some comments on how they did the gap identification. So they're able to identify the challenges of poor hand hygiene. Early in the morning, Dr. Lois had mentioned, we score very low when we audit hand hygiene practices. Dr. Rebati had pointed out, even in the very well-resourced facilities, because of fear of pilferage or other concerns that maybe an institution will have, then you have either inappropriate use of PPEs, maybe we use them for other reasons, or you fear people will siphon them out of the institution. So it's either the inadequacy in supply or the inappropriate use of the same. I don't know how many have used the hairnet. Sometimes we have an aerobics facility within KNH. Sometimes we find what the people are using to hold up their hair is the theater hairnet. So sometimes you think, if we look at the PPEs we have in our institution, how do we use them? And now maybe that is what is making us run out of the same from the institution. Inadequate cleaning and disinfection. For those who want to assume for private facilities, there's enough resources dedicated to cleaning and disinfection. But for public resource facilities, it seems almost like a by the way. Let's buy the food and the medicine, and when we come to cleaning and disinfection, it may not feature highly on the priority list. The cohorted patients, because like we mentioned, our occupancy is definitely more than 100%. Then there's also the challenge of lack of knowledge. Remember, this is a training institution, and so you have high turnover of clinicians, nurses, prescribers, all those caregivers. There's quite a high turnover because people have to learn one way or another, and non-adherence to the hospital-acquired infection care bundles. Okay. So non-adherence to the hospital-acquired care bundles and the contamination and reuse of equipment. Remember this high turnover, we have many staff. And so there's a chance that some might forget the processes. You forget if we need to decontaminate, what is the procedure, or we have run out of supplies and we are trying to substitute. So what did the team do? For starters, they closed the unit so that we don't have any more clients going into the same place, to the same unit. They addressed the issue of traffic flow. You have the patients, you have their mothers, and you have the well-wishers, the visitors, we have the students. So you have to do a lot to control the traffic, the cohorting, and I believe Dr. Luvala and the newborn team will be able to address, to highlight that a bit more. And where they identify the confirmed cases, they also cohort, meaning separating them too, and putting also emphasis on contact precautions for all staff. Earlier, there was also what Dr. Lois had mentioned about that this focus a lot on environmental decontamination, environmental swabbing, being able to identify it, because most of our thinking is the dirt is on the floor and in the dustbin, and we're not really conscious about the other contact areas that the patient comes across, or even ourselves as the healthcare workers. And they're able to identify the Kleb pneumonia in the milk room, soap surfaces, the tap, the entry door, common medicine trolley, areas that probably we do not consciously think about when we are thinking of cleaning and disinfection. Then also we have the issue of we have contracted our cleaning. So the cleaning staff will be rotational. And now if you're not dedicated to a unit, you will not realize this, the kind of protocol you need to follow. And so now you need to do a lot of training and even preferably have dedicated staff who now know exactly what is expected in that area and reinforce the proper decontamination of instruments. There's a lot of training that was done, a lot of sensitization of hand hygiene, which is very easy. I hope we'll have a chance, Rachel, you remind us how exactly we should wash our hands, so that if we are the only agents who live here to our institutions to tell people to wash our hands properly, we can be able to do the same. And also for the mothers, remember this, the children, the newborns are admitted with their mothers. We can do all the good practices, but we also need the mothers on board. And a champion for the mothers was identified when it comes to hand hygiene. So here we see a lot of the support from lab in terms of being able to screen the babies, to do rectal swabs and identify those who actually had the Kleb pneumonia. And they found of those also 7 had CRE. Now, other measures can tend to require a lot of resources, but at least you have a plan for them. To request for more space. You guide whether you actually got the more space. For more staffing, we are, I think almost all public facilities, and I think even private facilities, staffing has a financial implication, and how much can we actually, do about making sure we have adequate staffing. And repurposing of one of the nurseries with the hope that we can have the NBU eventually expanded. So for this, I want to acknowledge those who worked on this initially for a forum, an ECO forum, a platform to be able to learn from various institutions of when we look at cases that we come across. And one I appreciate is in the room, Dr. Roslyn Kinuthia. I know she represents a very big team from IPC. We have Dr. Ali Kasim, who is our clinical microbiologist, and Dr. Anne-Marie Masharia, who is our head of department for pediatrics. So with this in mind, as being the scenario, as the event that took place, and we want to do 2 things. If for us who it happened, we do not want it to happen again. So we'll use the core elements of AMS to think here as a role, how do we make sure that it does not happen again? And for those who are new in their roles, like for Parklands, the new establishing antimicrobial stewardship program, how do you make sure you don't get to this scenario? Because unfortunately for healthcare, people only talk loudly about us when something goes wrong, but we want to, even if there's no praise, we want to do something because it has an implication of life. So to share the next. So with that in mind, now from there, I've done the talking. Now the rest will be, we'll have to do a lot of legwork, because now it will be the talking from this other end. It will not be with that scenario in the background. We will go through how we are going to not again or not have a similar event in our institutions. Okay. So I'll use the simplified core elements for okay. Well, they stop share, reshare, stop share, reshare the room. I can have the benefit of being like a teacher and say so and so is the attendance. That can guide, because I know we have nursing represented. I may not quite remember where everyone is seated for nursing represented. We have lab, we have quality, we have the clinicians, we have the pharmacy team, we have IPC. So I hope we are good in terms of that we have the right slides for the benefit of the online audience. We are good? Okay, thank you. So this I will not re-emphasize, but we acknowledge that antibiotics are misused. And the consequences are clear, that we'll end up threatening having access to interventions that work, that we are promoting the spread of AMR, and here we are with us being in a low LMIC. Our challenges are infectious diseases. You'll end up driving the incidence rates for MDR TB, for malaria, and then we also have the implication on increased healthcare costs, and where I like to talk about adverse events. So a stewardship program, for those who are new and setting up one, is basically trying to educate and persuade those who are in your facility to be able to follow evidence-based prescribing so that you can step antibiotic overuse. It has a long definition, but I like it's a persuasion, it's a behavior change. And we are going to working through this room because this room represents all these areas, starting with leadership commitment. So I would ask, probably by a show of hands, and I don't know how for online, whether by a show of hands, how many of those facilities actually have the leadership management in terms of your leadership structure, whether it's a board, whether it's the directors who have actually adopted formal statements with regards to supporting antibiotics use. Here, at least we can raise physical hands. Okay, so we have the institutions, a number of institutions where that is adopted. I want to hope the same is the case for those who are joining us. So it is important that we actually have that, that you would want senior leadership in a facility to adopt that. We were having a brief chat and we realized that a lot of these committees, they actually draw a lot on your time and effort to make sure that you actually implement the interventions. And so if there's no good management support, then you don't realize just how much time you have to spend to ensure that all the AMS interventions are actually put in place, because the rest of the routine work, if you are an ID physician in the facility, they don't stop your routine work because you are in AMS. But how do you make sure that you can be able to play a part and be able to address, to reduce the likelihood of, make your contribution to stemming AMR and still do what it is that we say core business that you are recruited to do. So we need that to need protected time, need to be able to have the institution recognize that when there is either maybe you need to do training or sensitization or activity that is AMS, that they actually gave you the mandate to do that and they need to support. I like to think of it that if you mention an activity or an intervention, that this is might be difficult to see, but it is basically the appointment letter for the AMS committee with the terms and references, and it's signed by our CEO. And that is a level of, in terms of commitment in regards to setting up the committee and supporting it. So with this, now if you mention that for the sake of AMS, we need to expand the space, it's almost like, I don't want to say putting a guard on somebody's head, but like I'm twisting. You already committed at your level that you're going to support this intervention. So we say, and I'm sure there are those who are joining us from county, and they have now the county antimicrobial stewardship committees who need to do the same. offer the same support for their facilities. How many can say that they are the ones who are called or they know who to call when you want to raise an issue regarding stewardship? Who is it? Who do you look for in your institution? Yes, Nairobi Women's.
Yes.
So who is the one who, if we hear that you have the patients go to social media and say we are having our patients living with infected woods from your theaters. If that has not happened, but if that was the report, who is the person who responds?
Myself.
Yourself, you're there?
I'm the chief medical officer.
So you are also the head of the AMS?
Yeah.
Okay. So now now that is high level governance. So the commitment from your end should be much stronger because you're the boss who directs. And I hope in the other institutions for Jalaram, is that the same case that we know if there's an issue, who do we call them?
So we have a full-time IT specialist. So she is the first point of contact. And the second point of contact is me, that is the head of the policy.
For Avenue, is that the same scenario? If there's an issue, which we say falls in the realm of AMS, who do we call?
We have the in charge of pharmacy, the pharmacist, who is also the chair of the MS team.
So in those who are represented here, there's at least a point. The person who will say, like the spokesman for the police, the one who will follow to find out what went wrong and be able to follow up for any actions. In our situation, we have an ID physician as the lead. Now, we are talking about antimicrobials and their medicines, basically. So do we have a person who we call in our institution? It's for me, I can say, this I know who we'll defer to. If we have anything related to medicine availability, we don't have a medicine, or ensuring that we actually have available what we need to enforce guidelines. For the other institutions, is that the same case? Do you have, or it is, we say everybody's job is nobody's job. We have everybody helping, but somebody has to be responsible. So is that the situation in Gertrude's?
Yes, we do.
So, and I want to hope that even for those who are joining us online, that there's actually somebody who will know if we need to ask questions. If an item is missing, most of the time when Lois calls, the default setting, if it's something you cannot address, I know at least I can escalate to my boss, Dr. Birichi, and I'll be sorted. But at least there needs to be a point person who responds. And drugs are in the hands of all of us. So we need to ask ourselves if you're in the ward, you're the nurse in charge, who is the champion who will follow up? If we have said our guidelines are for surgical prophylaxis, we use cefazolin, we have ceftriaxone and cefuroxime, which is left over in the ward, and we have a patient to take to theater. Who is the person who will be responsible to make sure that even within the ward, even if you're not the pharmacy person now at that level in the ward, who is the one who's going to make sure that we actually use? Now that we know what is in the guidelines, who is going to be responsible to let the others know in the team what is required of us? So we have a pharmacy leader, we have the medical and clinical officers to present, depending on the kind of institution you can have both. And they are very key in being able to support the interventions. Then we have infection IPC. I think a number of times we only think of IPC as a reactive when we want to react to a situation like when we had the outbreak, the Klebsiella outbreak. But we need to think about what is it that IPC can do. So in this case, I will ask Rachel, this is your moment to tell us. And also Damaris, in terms of IPC, and we're looking at now how it is IPC contributes to AMS. So we had the triad, we had ASP, antimicrobial stewardship, diagnostic, and IPC. So just give us an overview, a little bit of how you support AMS in your facility.
Okay, thank you. IPC is involved in surveillance. So in collaboration with the labs, once they have flagged a microorganism, we follow up and try and discover the preventive measures and how to terminate the spread of the disease. So we will identify the place, for example, now that we're using NPU, we will walk there, do a surveillance and monitor how the outbreak, if we can call it that. And then we get the preventive measures and we do trainings in order to train the staff, all the people who are involved there. And then we also, through the administrative office, we draw a plan on how we are going to improve, guided by our standard precautions for IPC. We do almost, we can call it policing. We camp there and try and trace the spread of the disease and how we can improve on it until our patients are safe. We like to involve everyone walking into the unit and out. And our standard precautions include the PPEs that are used, the medications that are being prescribed, if they have results, culture results involved, and also involve the caregivers, including the mothers, the doctors, and the people doing environmental hygiene, public health. We work in collaboration with different departments. Yes.
Okay, now not moving very far from there, and to ask Dr. Lubala, you also highlighted that there's a lot of research around antimicrobial stewardship and also coming from the angle of NVU, and that for my presentation is a focus. What is it in terms of IPC have you been able to sustain? Because there's a lot of gaps identified. So what changes have you been able to sustain so that we can have a never event?
Thank you, Dorothy. Well, I think thanks for that question. I think it raises a very pertinent component of sustainability when once you institute change, and so that it's not a one-off, it becomes incorporated in the day-to-day work. So I think one of the things which we've been able to sustain so far is the flow into the newborn unit. So we discussed about managing who comes into the unit, being identifying who is coming into the unit, and enforcing hand hygiene at the point of entry. So it does seem on paper seem very simple, but we actually did, for instance, we did have a barrier. We did have somebody responsible for checking who is coming into the unit initially. So we now have that anyone who walks into the unit signs in. And the reason we have that signing in is because for a variety of reasons we did have lots of traffic into the newborn unit which had nothing to do with them in the patient care. So we've been able to stop that or at least mitigate against that. Everyone who walks into the unit is now actually supervised through their hand washing, so it doesn't matter who it is. So of course there's a bit of pain points initially, but that has become the standard. But the flip side of the coin, there are things which are easy to sustain, but there are some things which are harder to sustain. So things which require extra effort beyond perhaps introducing a structure into place. So for instance, being able to do our own internal audits and have our teams, besides their routine work, being able to incorporate IPC work into the as a daily standard of care, besides the bedside work that I do for the patient, to have a self-awareness of the IPC as I walk into that room. So that is a bit more difficult, and I think it requires a bit more work. I'm sure that's a question.
Yes, you highlighted what it is you've been able to do, sustain access control, managing the traffic. But you've raised an issue that one thing that is very hard to do is maintain behavior change practice. Because I don't know how many people can remember many times they washed their hand when COVID was a big threat. Then you think about now, how often do you think to wash your hand now that we know we have vaccines and COVID is not the same level of threat? So that maintaining that behavior change is a challenge. So I'd like to ask Damaris, taking note of what it is, we say you have now learned from our experience. What is it do you think you will take back to your institution to be able to implement in terms of, you mentioned you're both in IPC and quality improvement?
First, I want to acknowledge my previous experience. I worked in Nairobi Hospital for around 7 years. And that's where I got much of my experience in terms of quality and infection control. So the skills, the team, the practices, the knowledge that we need to impart. That time I was just a ward nurse. I remember I was working in a very busy ward, surgical medical ward. So I got much of the knowledge from there. Despite being new in this facility, there is much you can impact to the new facility. For instance, what we do in the IPC, I am in charge of IPC in the whole facility. In terms of infection prevention, I work with the lab manager. We're able to pick up immediate cases that need isolation or immediate cases that need the AMS. For instance, if we do a blood culture, I am the first person that gets the report. I was just seated here and saw a cholera case, so that I'm able to pick up immediately in relation to the department that will handle this patient. Another thing, we work hand in hand with the ward nurse. If we get our own patient, the standard we do is do our swab to roll out in any growth of a bacteria. And then also, it is a challenge. IPC is a challenge globally. Like Dr. Lois was saying, hand washing is not so common with doctors, so it's a song we keep singing to them each and every day. When you do the audits, actually, they're the ones that score very, very low. So it is a collaborative role. It is, as you are saying, a time-consuming role, a role that really put much of your efforts in time and all that. But at the end of it, we're able to get it. And then we look at also the neonatal. If we get a neonatal sepsis, we pick it up and we're able to establish, is it facility related or is it prenatally related? So we go into history taking and we put the measures into place. Yeah.
Thank you. You've actually even mentioned a little on the lab support, because we had quite a lot of the on lab support and we're not well on it, but thank you for highlighting that, and also the role of nurses in implementation and supporting. So I just want to ask, there are other additional members that a number of us probably not have them within our teams, the either ICT staff or quality improvement staff, but we can be able to draw on that. Is there anyone can make a comment on if you, in terms of ICT, how ICT can plug in or how you can plug in with the ICT staff to support AMS? Yes.
So last year, we were doing our first equivalent hospital. And we have an ICT department, but we don't have one dedicated to us. We use them now when we need to do audits. So we had someone come, because during a point equivalent survey, you need data at a particular time on a particular day. So they helped with pulling out the data for the patients in the hospital at that particular point we had instituted. And also IT has a lot of roles in stewardship. Like, for example, now we are working towards having now a restricted antimicrobial being color-coded, prescriptions for antimicrobials having like indication, is it empiric, is it evidence-based, is it prophylactic? So there's a lot of expanded role for IT within antimicrobial stewardship. So if you're fortunate to have a team, you can plug in and have them assist.
Thank you, Winnie. So we have talked a lot about the interventions throughout the day, the interventions that have been put in place to support AMS. So I will not go into details about them, but there are a lot of policies that are in place. You've also talked about actions and steps that you put in place, the committees, and there are various interventions that you can have, including having specific guidelines, syndromic guidelines to be able to offer a guide in terms of what you give for empiric therapy. This was our first edition for empiric therapy guidelines, and next week, as was mentioned earlier, we'll be launching the updated version, and it has clearly spelled out for what category of patient should be on one, what medication, a guide, a handbook that is given to all clinicians, also sensitized across the hospital on how to utilize the resources for diagnostic stewardship. And that's just an outline of how it looks like. And we're also going to be launching our first guideline for surgical antibiotic prophylaxis. It looks different from this. And one of the things that Winnie has mentioned, even as we continue interacting, is the regular report, the regular audits, and these are supposed to guide how we, to guide us to know what interventions are working, what is not in place, identifying the gaps and being able to address them. So in terms of monitoring and evaluation, I just want, if Dr. Kama, you can make a small comment, because I know you're passionate about continuous quality improvement. And with the bias with the newborn setting, just think of that intervention that was there for IPC and sustainability. What in terms of monitoring and evaluation are you thinking about, or is already in place to make sure that you can be able to check, are interventions in place, and is it actually making a difference?
Okay, thank you. So what I've been thinking about is the clinical impact and cost effectiveness, and really just narrowing it down to what the antibiotic use is in the unit. And like looking to what you presented, what I wanted to know was what was our antibiotic usage before it happened. And now that we've implemented what we've implemented, has anything changed? And I think just doing point-driven surveys to just have a look at the antibiotic use is something I'm interested in. And also cost effectiveness, looking at pharmacy data, finding out what is what's the antibiotic consumption and the costing, and it actually helping us in terms of reducing the cost to the patient. I noticed that average length of stay in the newborn unit is 14 days. Could it be shorter so that the cost to the patient is less through AMS?
Thank you. So we need to think about cost effectiveness, and that will probably one way to be able to drive the point to management. And it's good we also have management within us that actually investing in stewardship program is important. So there are those process measures and outcome measures that Dr. Kamaho has mentioned in a nutshell, so I'll not go into them. And like forums like this for education and training, so that we can be able to grow. And how we also package our messaging regarding AMS. When we have restriction policies or other training, we want to get people like hand hygiene. How do we make sure that the hand hygiene that was talked a lot about during COVID is even sustained post-COVID? Now we have cholera, so I don't know whether now cholera doesn't come with the masks. It comes at least with a washing hands. So how do we make those messages continue to play around in our minds? So I'd like us to think about that in the so that we can all work at just when we have any quality improvement interventions that we are able to sustain them. So in the next few minutes, whether this will work if I stop share and start share. Whether we breathe or we have lunch at the back of our minds. So I want to just see how we can all play a role in pharmacovigilance, which is actually in summary just talking about medication safety, patient safety issues. And the antimicrobials we're looking at is a patient safety concern. And we all have a role to play in this, even those of us, clearly I used to say before, what is difficult when I'm introducing myself was being able to help people pronounce my last name. Now what is difficult is getting people to say pharmacovigilance or pharmacoepidemiology. So now I'm thinking maybe if I look for a PhD, I look for the next difficult thing to associate myself with. But I want to hope that I'm going to make this at least simple for you to see how PV and AMS come together. So as I hope it has changed for the online audience while we are getting this. It's not on slideshow. Okay. Whether that is now a slideshow. So it's just bringing together, so I'll not take too long, but just introduce the concept of PV and AMS outfits. Okay. I think this device is very different from mine. It's like the Android version, when this one is a little bit, so I'm not too sure how it's going to get there. But as we are working on that, so for PV is looking at monitoring the safety. Oh, sorry, Dr. Wendy? Oh, okay. Oh, okay. Okay, thank you. I take note that from the guy in the team. So pharmacovigilance, not pharmacovigilance. So pharmacovigilance in the context of AMS is it's a process, it's a science around monitoring the safety of medicines and taking any actions to reduce the risks and increase the benefits. So I like to use that definition. I find it much simpler, but it's almost gold standard to always say that it also involves activities which revolve around detecting, assessing, understanding, and preventing adverse events. But going with the EU definition, we want to monitor the safety of medicines. We want to make them available, but we want to be sure that they are not going to cause harm to the patients, and we want to make sure that they actually work. So anything we do around that, making sure our medicines don't cause harm. If the patient is allergic to an item, we don't prescribe an item within that same class. Or if in case there's a challenge with therapeutic ineffectiveness, like I'll point out in the scope of PV, when we have issues to do with quality issues that have an impact on therapeutic effectiveness, so that means the medicine doesn't work. And sometimes maybe the challenge of saying that we want to use the reserve antibiotics is majority of the time you see in the market, or even most of facilities, the reserve antibiotics, we have fewer suppliers. So probably chances are you're probably procuring a high-end product. But for the other, those which are in access and watch, because the market is much bigger, then you see everyone who wants to make a buck will target those because it's easy return on investment, it's easy money. So we have to keep watch, even as stewardship teams and AMS champions, to make sure that what we bring to our facilities is of good quality. And then we also watch out for medication errors. And here I'm thinking, did the patient need to be on treatment and they missed a dose, and that could have an effect on their outcomes? So we find that they only got for a 5-day treatment, they only got day 1. For the 4 days, they were not getting anything. And then now when the clinician, the ID physician comes and they will say, they have been on 5 days of treatment and not improving, but they've actually been on 1 day of treatment. So we changed the antibiotic, not because it was not working, but because we're not giving it appropriately. So for pharmacovigilance, we want to find what are the unknown safety problems. What is it that we didn't know that is happening to the patient? And then for those problems that we already knew, what is there an increase in frequency? So I'll give an example. If we know that there are patients who will be allergic to sulfur medications, but you have a certain percentage of patients who you identify, but then you suddenly find an increase in frequency. Is it that we are not asking our patients if they are allergic, or do we have contamination? See, before the Pharmacy and Poisons Board, and I want to thank Dr. Birichi for when they instituted that we stop the packaging in bulk. The mukebes, those who have been in pharmacy practice for a while, we joined when we found literally every medicine was available in a big container. So if the container, if you decide you want to use a container like a gorogoro to measure, so you want to give to the ward medicines, but where to keep the medicines, you also package, you give them the empty container, but you assume it is amoxicillin that they are going with to the ward, but putting it in a previously empty container for cotrimoxazole, and it is dusty. So we really know that you find it's a lot of work to maybe clean it and the like, but I want to appreciate that now we are more into unit packing, and that reduces some of the unknown safety, or reduces the safety problems that we you identify that as a safety problem, but when you see it increased in frequency, you go back and see what is in your system that is promoting that increased frequency of the problem. So in summary, pharmacovigilance aids in promoting safe and effective rational use of antimicrobials, promoting awareness to patients and general public through effective communication, and identifying the risks associated with the use of antimicrobials. The whole of today, we've been asking ourselves, do we actually need that antibiotic for that respiratory tract infection? And for those who we give and they didn't need it, what can we do to now make them aware that they don't need a certain medication? And for the rest of us to treat our anxieties. So there's a caption that says that the antimicrobials are anxiolytics for prescribers, so that at least you feel you have done something to the patient. So if we are able to encourage rational use, we minimize resistance. And that way we're able to reduce risk when we are using medicines to our patients and increase the benefit, because now the medicine will stay longer in the pipeline. So a lot of the earlier presentations showed us the various graphs, the data regarding where we are in terms of resistance patterns, in terms of infection rates, just basically on antibiotic use. And want to challenge even those who are following us online, that let's see how we can be able to collect pharmacovigilance related data that can support us to know where our problem is, where our pain point is, so that we are not at the reaction. We wait for a big blow to react, that we are more proactive. So for this study in the Netherlands, where they use pharmacovigilance data as a trigger to identify antimicrobial resistance, what we are looking for is any reports which is AMR relevant regarding adverse drug reactions, and they are also looking at what are the frequently reported antimicrobials. Number, use. Resistance is driven by use. So you look at what are we commonly using, so that you can start to tell you what could be a potential problem. Then if there's off-label use, if we decide we are restricting rifampicin to the TB program, but it is used for something else, would that be considered off-label use, and would you report it so that we can know we are having an increased use of a, let's say, reserve drug in a different condition? Therapeutic ineffectiveness. Now, most of the time we say this drug doesn't work, and for say now for the clinicians, most I say it doesn't work. If I prescribe this particular brand, stick to that brand because I don't trust the others. But what can we do to collect data about what doesn't work, so that it can inform us when we are procuring or sourcing for medicines to actually to stick to the products that work. And when we use a product for an unapproved indication, I think the time for COVID is the time for a lot of experimentation. So we're allowed to use anything for any drug that we think can work. We're allowed to use it anyway. A lot, when I think of now those who are in the regulatory space, are we able to even capture? Can someone be able to report data on whether a pathogen is resistant or drug resistant without necessarily sitting down to do PPS or a drug utilization study? What is it that can be easy to capture, so that now we can be able to inform the rest of the team as routine data? So this study, now I realize the orange is not, but what they found is that the most frequently prescribed tobramycin, colistin, ciprofloxacin, doxycycline, astriona. So now if we find, if we say colistin is a reserve drug, but it's appearing as the most frequently among those reported with adverse events, means we need to do an intervention around our reserve medicine. They also reported a lot of off-label use of drug ineffectiveness, product use in unapproved indications. So we ask ourselves, did we not have guidelines? Do people have access to the guidelines? Do they understand what they are, so that now we can have a targeted intervention on that? I don't think our local PV system will capture pathogen resistance or drug resistance, but that's something we can think about. How can we be able to document the same and guide our practitioners? For this study in India, where the PV pharmacovigilance initiatives around antimicrobial use they highlighted that you have a lot of the irrational use is unchecked. We don't document. And then we have misuse of antimicrobials across the sector with animal, human health, agriculture, and now the other is in our soaps. Those are times when everything was herbal, Colgate, herbal, anything good was herbal. But now I think since COVID, anything good is antibacterial. So usually I tend to run away from the antibacterial soap, but we don't feel confident unless maybe your lotion is also has an antibacterial agent, and that is also driving use. This paper looks at now in our routine practice for those who are in pharmacy or as support supply chain, even making sure that we have stable supply chain system, having products available. If we say we'll have access, watch, antibiotics, or antimicrobial agents consistently available, when they are unavailable, it drives the use of the wrong product. And this would probably come earlier, but just a study that showed that we have issues with the quality of some of the products, and we need to also have our eye out. So when we have concerns with quality issues, we need to bring this out. We need to highlight them, report them, so that we can be able to institute mechanisms to address them. So as I finish, I'd like to ask Dr. Berici, in terms of ensuring in terms of ensuring confidence, in giving confidence to our prescribers of the products that we have, of their availability. Probably you could highlight to the rest of us, how have you been able to ensure confidence in the products? You are in a public facility, and also availability.
Thank you, Dr. Iwat. Thank you for the wonderful presentation. In terms of KNH as a public health facility, there are quite a number of systems and processes we have put in place. From our medicines and therapeutics committee, at the apex we have a selection process that is based on evidence of efficacy, safety, and at the final stage we look at the cost effectiveness. We have panels that do selection and look at the evidence. So if the studies that do support the use of the medicines is either grade 1A, 1B, or 1C, there is a good chance that that medicine will be selected for use in the hospital. Beyond selection, we go through a technical evaluation process when we look at the suppliers who have expressed willingness to supply to the hospital. So we have a process of looking at, out of all these registered products, what is it that we should choose for stocking in the hospital. So we do it in 2 stages. We have a preliminary evaluation stage where we look at whether the bidder meets the requirements of a good corporate citizen. Do they obey the law? Do they pay taxes? Are they registered with the regulatory body, the Pharmacy and Poisons Board? Do they have qualified personnel to handle medicines? Then we go to the second stage of product evaluation, where we look at various parameters, including the registration of the product, whether the product has a reference to a pharmacopoeia standard, and several other parameters to do with that product. We also require bidders to submit a certificate of batch analysis for every batch that they will supply to the hospital. Beyond that, we put a pharmacovigilance system in place to monitor those medicines during use. Also, at the point of receiving the medicines at the hospital, we have an inspection and acceptance committee that compares the sample that was submitted for evaluation against what is delivered to the hospital. So in those different stages, we are able to assure quality. And for any medicines that will be supplied to the hospital, we ensure that the supplier has a manufacturer authorization to distribute that product on behalf of the supplier, so that we are able to cut down to those people who are able to infiltrate the supply lines, either with the counterfeit products. And during the use of period of use, where we have cases of therapeutic failure, we are able to sample and send medicines for analysis. We work closely with the drug and analysis and research unit at the university and the National Quality Control Laboratories. So I think with those, we have quite an effective system that assures that the medicines that are available in the hospital are of good quality, that they are safe and effective. Thank you.
Thank you very much for that very comprehensive overview. And I want to hope for those who come again a public facility, you have, it helps you build confidence. And I want to hope for clinicians, and to finish this and request Dr. Owende to just make a comment around that, because she chairs our MTC and making sure we have appropriate, we actually have appropriate products and we have quality also in the mind. So this, like just thinking the challenge with having availability of other molecules for antibiotics are just challenging us, and I want to particularly also challenge those who are in the pharma industry to think of antibiotic business not in the standard market business like when we are doing it antihypertensive, where when you introduce a molecule that you want to see the numbers go up. In this case, we want to not see, to be appreciated. If the numbers don't go up, we want to preserve that molecule to stay in our supply chain for longer, because we need to think of a different model. And I hope a different model will come to reimburse those who are developing new molecules, so that, because we say we use it, resistance follows it like night after day. So we want to limit its use, and therefore even the marketing message needs to come out that way, not drive up the numbers, but preserve an agent. Because we want to think of antibiotics like the way Dr. John Rex thinks of it. You think of it as a good fire extinguisher. We want to continue producing fire extinguishers. We don't want them to run out of business, but we don't want to have an incident where we have to use it. In this hotel, there's I was going to say AED, and I thought people hear IED, but they did a security check before we came. So there's that automated external defibrillator in case somebody has a heart attack. But would you say you want to buy very many of them because you hope many people will have a heart attack, or we just keep it as a safety measure? So if you can think of antibiotics as a safety measure, as opposed to as a necessary, like a, I don't know whether we'll say a vitamin or a supplement. We don't think of the antibiotics as a supplement. So that is my last slide. So as I am there, I want to ask Dr. Owende to just give a few remarks in terms of as our leader, in terms of our governance structure represented here for Medicine and Therapeutics Committee, how we can be able to assure quality and safety, and also support for stewardship programs.
Thank you, Dorothy. I think Dr. Bridge has given a very elaborate answer, but I'll just add a few points to what he has mentioned, that we use standard treatment guidelines that has really helped us to come up with the treatment protocols. And so clinical teams are encouraged to present to the medicine and therapeutics committees before consideration. So other than that elaborate process that was mentioned, standard treatment guidelines are very important in selection of medicines.
So thank you very much. And with that, I wish to hand over the meeting back to Dr. AMR.
Thank you again. Big hand for her. But if not, you are here for lunch. He has like 5 questions to answer. I think the first question is the difference between pharmacovigilance and post-market surveillance. Yours in duty.
Okay, so pharmacovigilance is a broad term. So when the board is talking about pharmacovigilance, when they're looking at this safety of medicines. So you're looking at adverse drug reactions, adverse events following immunization, medication errors. Post-market surveillance is looking at the aspect of quality. So what is in the market? Is it of good quality? And then what can we do to ensure it's of good quality? So sometimes you might find you're in a facility and the regulator or yourselves, you could be able to decide to do what we call a post-market surveillance. You want to sample and see what you have in supply. Is it good quality? So I hope that explains. Vigilance, not like watching, like when the police come with alcohol to make sure that there's safety of the road. Vigilance is safety of medicine. And then post-market surveillance is the quality, focuses on the quality of medicines.
There's another question about this. I'm sorry for the writing this to you, but wound dressings, antibiotic wound dressings, can they cause antimicrobial resistance?
Good, we have the opportunity of wound care. So you could be able to give us.
Thank you, but I had the same question.
Yeah, now that I to Dr. Wende.
I guess this depends on the type of wound. Has it been specified? But say for surgical site infection, one of the more important things to do is what is known as source control, that you determine where the infection is coming from, because most wounds for surgery will be superficial. Infection will require cleaning and dressing only, and you might not necessarily need antibiotics. So when cleaning is done with simple solutions and not antibacterial, like normal saline, clean normal saline, and dress the wounds. But I know there are certain sophisticated materials now that have been used for wound care that encourages healing, and so they make the wounds heal faster, but not necessarily antibacterial. So we do not encourage the use of antibacterial products on the wound. Thank you.
So, yes.
Maybe to add some remarks. What is key is the exposure, whether the bug is exposed to the antibiotic and whether the concentration that the bug is exposed to is within the range that would drive resistance. The other key thing is for most of the antimicrobials we use for topical application, most of the regulators have tried as much as possible to restrict those molecules to topical applications as opposed for formulations that are available for systemic use. Thank you.
So I hope that was answered. Now
There's one question that was lingering about Candida auris. There's a huge amount of resistance for Candida auris, and should you continue using oral
for especially patients who are HIV positive? It's still recommended to use prophylaxis?
With the one who answers that best has just come from a fellowship expanding our knowledge in ID. So Dr. Juma.
We're talking about prophylaxis, separate prophylaxis in HIV positive patients.
Candida auris. Candida auris. Yes.
Yeah, it's separate prophylaxis to prevent Candida auris. Okay, please repeat the question.
There's a worry that there's a lot of resistance with the prevention of oral candidiasis with the current. I think what is the current? People are using oral antifungal for that. I don't know. I did clinical a long time. So there was a concern that there's a lot of resistance for especially HIV patients.
So I think maybe an attempt to answer that, the way I've understood it. So I think to prevent development of resistance, just use, make a diagnosis first and use an antimicrobial in the appropriate situation. So for example, if your patient has candida infection in the mouth, I mean, it's indicated for you to use an antifungal in that situation. So maybe what would drive resistance is if you don't use the antimicrobial appropriately, or you use empiric therapy, you don't make a diagnosis. Yeah. So just knowing your guidelines and using the antimicrobial when it's indicated and for the duration prescribed.
So there's a question here for IPC. So this is for IPC team. Among the strategies put in place to control infections, I don't know if they missed that. Is it routine vaccination of healthcare workers part of it, and how is this implemented? I think of COVID, hepatitis B, vaccines mentioned a few. Or are we just walking around with multi-drug resistant things because we need to be vaccinated? Should I concern? Anyone from IPC to take the answer?
Okay, in regards to vaccination, yes, it's mandatory. In most of the 3 vaccinations that at least every healthcare worker, mostly the nurses, because we spend much more time with the patient with hepatitis B, COVID, and now we are moving into sensitizing people to get vaccinated against cholera. The reason some of the challenges comes with the cost, but discussion of different institutions, you'll get whereby hepatitis B is offered free for most resourceful institutions. COVID, of course, was free. Cholera comes with a cost. So like, let me say in our institution, we are looking into whereby the hospital can pay for us half of the cost, and then the healthcare worker can pay half of the cost, which of course is deducted from your medical cover. And yes, I can say it contributes to a role of preventing infection, because once you're vaccinated, for example, against cholera, the chances of contracting this cholera and we're getting to a situation whereby it's becoming a big outbreak in our country currently, it prevents you as the healthcare worker from contracting this infection. And yes, it's key in preventing infection.
For those who work with children, there are certain other vaccines that are recommended. But yes, healthcare worker vaccination is part of what we see. We have heard outbreaks of pertussis. So this is working in different areas, pertussis, influenza, which are important vaccines to give to healthcare workers. And especially for the younger healthcare workers in the young female workers, we also advise they get AMR vaccine for rubella, congenital rubella. student, right? So it's one of those. So it's still an ongoing expanded list of vaccines that should be available for healthcare workers.
There's a last question. I hope Dr. Mary Banks is, because you said at the end of the session she can make a comment. I see her hand. Yes.
Yeah, so my hand is now truly up.
One last question was.
Sorry, can I speak?
The question about the report done by KU Biotics. What is your take on this? There's a report that was done by KU on antibiotics, and some antibiotics from somewhere really failed a lot, around 38. So what is your take on the failed antibiotics being used in circulation?
KU. Kenyatta University, I'm a Kenya. Okay, I'm not from KU, but Dr. Bilichi, perfect.
Just first to give a disclaimer, I'm not from there, but I know the study was done around 2016. That is when the data was corrected. I think a lot of things have happened from 2016. I know the board has been very proactive in terms of post-marketing surveillance and in terms of the registration process and the kind of harmonization across the East African partner states in terms of regulation. We also have been impressed on the national quality control parameters to build their data so that we are able to what is the rate of in the effectiveness of the data available in the market. I know there is also effort in those many years. I don't think there is a cost to worry, but I think the relevant government agencies have their ear on the ground in terms of really regulating the market. Thank you.
Dr. Maritim, please go ahead.
Good afternoon. Thank you for giving me this chance to make some remarks. I hope you can hear me. Can you hear me? Can you hear me?
Where?
Okay. Can you hear me?
Yes, now
Can you hear me?
Yes.
Oh, okay. Sorry. I was frantic. I was trying to really shout. You can hear me now? I just wanted to apologize. I think earlier on my hand was up and I really struggled to find out how my hand went up, but I'd shared my link with Professor Anzala. So I realized I was joined twice and he was the one with a lot of burning comments, but now he's logged in and he might also have some few comments or remarks to say. So I think I wanted to respond to the question on use of, I think, fluconazole or azoles in patients with HIV for prophylaxis and in the setting of widespread, I think, or some Candida auris. So just a few comments. So when we look at Candida auris, it's a fungal infection that is intrinsically drug resistant, and it's thought to be a marker of like antimicrobial resistance or an MDRO antifungal infection. So it's not really that we have overused fluconazole and that's why we have Candida auris being the main pathogen. But it's not very clear at this point in time where it is when it's not causing outbreaks in hospitals. So another thing I just wanted to correct, we don't really recommend prophylaxis or antifungal prophylaxis in HIV patients. What we have evidence for is use in treatment, and we use it specifically to treat cryptococcal disease, which can range from asymptomatic cryptococcemia, where we call it preemptive treatment, and also in patients who are already confirmed to have cryptococcal meningitis. It is important in part of, in terms of your consolidation of treatment and your maintenance of treatment, and as part also of induction. We are hoping to have flucytosine maybe in the near future so that we can induce our patient with amphotericin B with flucytosine, and therefore leave fluconazole for consolidation of treatment, as well as maintenance until the patient's immune status is well reconstituted. We do not routinely give prophylaxis in HIV. We only use it for treatment. And I want to emphasize that because when you use a drug for prophylaxis, sometimes it can drive resistance. But in all our guidelines, we do not give routine prophylaxis with antifungal agents. You screen the patient, and if they have asymptomatic, you give preemptive treatment for a defined period of time. When you look at Candida auris, it's a fungus, a yeast that is intrinsically resistant to even fluconazole. Up to 90% of Candida auris isolates are resistant to fluconazole. So it's not even one of the drugs you'd consider in terms of treatment, where you isolate Candida auris and you're more worried about bloodstream infections. And the people who get bloodstream infections are the very sick, who are most likely going to be in the ICU, who have one or other forms of immunosuppression and are likely to come down with Candida auris. And they can range from adult to pediatric, and preterm children are particularly vulnerable. So in your facility, when you have Candida auris, you have to ask yourself questions around, perhaps you're even using a lot of antibiotics that would drive establishment of extended spectrum beta-lactamases, carbapenem-resistant enterobacterales, and other drug-resistant, multiple drug-resistant organisms. So it's just a marker that in your facility, you're most likely having a lot of multi-drug resistant pathogens. And therefore, that Candida auris is a manifestation of that generalized widespread use of antibiotics that would drive and evolve that resistance. So it would call for most of the things that Lois covered within our presentation, so that you're doing a lot of things around infection prevention too, to minimize your evolution of resistance. So I think those are just some of the comments that I wanted to make, and also to really thank the organizers for this session, because once we have this educational forum, then people are able to share their experience, others can learn, and really the purpose is to enable clinicians, because even decision-making with use of antibiotics is not very straightforward. And I know when we are leaving medical schools, many of us are very glad that you can prescribe antibiotics, but we are at that stage where we are saying for any antibiotic that you're prescribing, you have to put in place several considerations so that you're prescribing the right agent for the right patient based on the right indications. And you want really to have that evidence to say that that patient qualifies to receive an antibiotic because you have confirmed the presence of an infection that is caused by a bacteria. And therefore, the widespread use of antibiotics, where any patient coming to be admitted in the ward receives an antibiotic that is prescribed at casualty, should actually be a thing of the past. And what we are really trying to encourage, because there are several initiatives that are supporting establishment of microbiology labs in several of our county facilities, is really to urge clinicians to send samples to the lab so that you can practice evidence-based medicine, so that for any patient you suspect an infection, before you give the first dose of antibiotics, please send appropriate samples to the lab based on the clinical site where you think the infection is, so that if your patient has signs of meningism, then you have to do a lumbar puncture and send the sample to the lab. But again, balancing the cognizance that even something like meningitis is life-threatening, and you really want to give your patient to balance that administration of first dose of antibiotic with appropriate samples. For other patients who are fairly stable, then you can actually investigate the patient before prescribing the antibiotics so that you can have more isolates reaching the lab. And this came up earlier when we had the discussion where someone said that a lot of the data that goes to the national antimicrobial database is from the large hospitals and particularly KNH. We want to encourage the county hospitals to make use of the labs that they have so that they can also we can have a very good representation of other lower level facilities within that database. But this requires really a strong partnership between the clinical team together with the lab team and even the pharmacy team, because when you look at a lot of the antimicrobial stewardship committees, they are largely driven by our colleagues from pharmacy, which is still a good thing because we have to work together, but to enhance that clinical linkage and even the laboratory linkage so that we approach this together as one. So those are just a few of my comments, but thank you for this very insightful forum. Thank you.
We're at one time. I can see many questions. We're at one time.
Let's give a hearty clap. And I want to recognize Dr. Iwa. We've been working on this forum for, I don't know, more than 6 months. People premature, but it means sorry, you had a pediatrician leave. But I'd like to say that I would want to thank everyone who has attended this from all the hospitals in Nairobi. Have apologies from Mata Hospital, but we've had a very full house, both online. Online we hit 1,400 viewers, so that was quite impressive. And this shows that literally there's a big problem with antimicrobial stewardship and resistance. We are not where we are supposed to be, and with the questions we are getting online, we also don't know where we are. So most of the questions we are getting down from I think there's a facility in Uganda, they have a problem with this. There's a facility in Zambia, we've got a question from Ghana. So you can imagine how important this forum was. We would want to, of course, organize many in the future, but it all boils down to the facilities and the people in the room and the people online. If you can hear, you can change. Only things that don't change are buried underground, right? But we can change our environment for the better and protect our future antibiotics. With that, I want to close this session because most of you are very busy and your patients are calling you, I can see. We'll have another session with Kenyatta next week on Thursday, which will be on thrombosis. On Wednesday next week, 14th, online on thrombosis. And you know thrombosis kills more than antimicrobials in patients. So it's a very important session. We'll deal with thrombosis and the same committee led by Dr. Anne Mugera. So you can clearly see we are very inclusive and the ladies are really powerful in this committee. Please give them support in your hospitals and take up roles in leadership, in clinical leadership, and change and leave your name behind. Like you've seen, most of these people have presented documents with their names on it, right? Not foreign documents. We want Kenyan data from all hospitals. We want inter-hospital collaborations with pharma. As she has said, we are not here to sell drugs, by the way. We are here because most of our drugs are not being used the right way. That is what we call in our aspect pharmacovigilance in our actual departments, right? Yeah, when I was from internship, I was mentioning that many people used to work largely on, you know, in doing abdominal lavage with flagyl, right? But gone are these days. If you are in a facility that is doing the wrong thing, it is upon you to change that, right?
And if you're in a facility and you have this knowledge and you stick with this knowledge, that is the biggest disservice to medical fraternity. You must impact the knowledge you have gotten from the forum to other cadres, right? We have clinical officers, medical officers waiting for you to go back, and they are waiting to hear what you gained from this forum today. I've actually gained a lot, sorry, but I'm not practicing anymore. But even if I were to go back to practicing economics, but I know what to do with my antibiotics now. Thank you so much, and God bless you all.